All right. My name is Tyler McCullar. I am one of the SHIP coordinators with the Upper Cumberland, Tennessee SHIP program. And today we're going to look at Medicare Advantage or Medicare Part C, known as both ways. So, what is a Medicare Advantage plan? It is a health plan option that you can choose when we're deciding whether or not we're going to go with traditional Medicare or we want to go the other route with Medicare, which is Medicare Part C or Medicare Advantage. I think of Medicare Advantage like a company that is contracting to take over our Medicare Advantage. So it is, in essence, a replacement plan that is taking over our Medicare coverage to provide that coverage for us. It is still part of the Medicare program and it's available across the country. Anybody that is in the United States and is a Medicare beneficiary, they can have access to Medicare Advantage plans. And they do provide everything that Medicare does cover. So you are still getting Medicare benefits. And they also have the ability to cover extra benefits that original Medicare just does not address, like routine dental, vision, hearing, even things like medical transportation, uh, fitness benefits, and other things like that. So, how Medicare Advantage plans work? They receive services through the plan. They have to cover everything that Part A and Part B traditionally covers. So they have to cover at least that 80% that Part A and Part B covers for hospital and medical. Some plans will provide additional benefits like the dental, vision, hearing, fitness, transportation, meals, like I said a few moments ago, and they at higher uh, co-insurance for certain things like procedures, lab tests, and things like that. Whereas with original Medicare, you would get that base 80%. Now, most Medicare Advantage plans, they will include prescription drug coverage in its base package. So it has that prescription drug coverage built into the plan itself. So when we're looking at which Medicare Advantage plan we're going to go with, it's very important to make sure that particular plan is going to have the prescription drug coverage for that person's needs for their medication list, because usually with that prescription drug coverage built into the plan, we're stuck with the coverage that they're providing. So we want to make sure that the prescription drug coverage is going to have the formulary to do everything that we need there. So with every Medicare Advantage plan, you will have to visit a specific network of doctors and providers, because each of these plans are going to have a certain network type, which means we're going to want to fit within that network and be able to go to places that accept that plan. And we will talk about the different network types here in just a few minutes. So it will be different from original Medicare when it comes to benefits and cost sharing. With traditional Medicare, the way that that base coverage works is as long as Medicare is accepted, they're going to pay 80%, and then we're left with the 20% of what's left. It works a little bit differently with Medicare Advantage. Typically, with Medicare Advantage, most of the plans are going to set specific copays for everything that you do. So instead of getting the service and being billed on the back end like original Medicare, a lot of times you'll have a set copay with Medicare Advantage that you'll pay at the point of service. For example, you may have a $10 primary care doctor copay. You may have a $35 specialist copay. You may have a $90 ER copay, and so on and so forth. You're going to have specific coinsurances and copays that you may have to pay on the front end instead of the back end. And so there are a little bit of differences in coverage that way. So if you are in a Medicare Advantage plan, you are still in a Medicare program. You're still receiving Medicare benefits. So even with you're a company like Humana, Blue Cross, Cigna, WellCare, Aetna, all of these different companies, you're still receiving your Medicare benefits. So you haven't given all of your Medicare rights away to that specific company. You still have your Medicare rights and protections when it comes to enrollment periods, protections against companies going out of business, guaranteed issue rights. So you're still going to get those benefits and those protections. You're just basically contracting your Medicare coverage out. So you still get the protection of if that plan pulled out of the Medicare market or went bankrupt or any of the other reasons why that plan may pull out of the market, then you would have the protection to be able to join another Medicare Advantage plan or even return back to original Medicare if that is what was going to suit you the best. So you do have those protections where if something happened to your plan, they're not going to leave you out to dry. So when it comes to the cost with Medicare Advantage, you still pay the monthly Part B premium. There will be some plans out there that do have $0 additional premium plans. That doesn't mean that that plan costs nothing at all. You are still paying your Part B premium, which that base premium is $144.60 a month. So you're still paying that base Part B premium. But there are plans that you may pay zero additional premium, so there's nothing extra that you have to pay on that plan. But there are plans where you might have to pay an additional premium on top of that $144.60. There are a couple of plans that may pay all or part of the premium for you. That's that's going to be different state to state on how that's set up. There's not a whole lot of plans in this area that I see that will pay part of the premium for you. I just haven't seen that here. Now, there are a lot of plans, like I said, that do have the zero additional premium plan, and those are available. So that might be an option to help supplement those high premium costs. On the flip side of that, there is some state and federal assistance when it comes to paying that Part B premium, which will be talked about in a later segment with help via TennCare Medicare savings programs that provide that assistance to cover that Part B premium for you. So talking about plans that have an additional monthly premium to the plan itself, it's what you would pay on top of that base Part B premium. Now, typically, plans that do have additional premiums, they will provide additional benefits, whether it be lower copays on your copays. So you may have a reduced copay, whereas one plan with a zero premium plan would have a $10 doctor copay and a $40 specialist copay. This plan with a $55 premium may have a zero primary care doctor copay and only a $10 specialist copay. And then that $55 plan may provide $2,500 worth of dental services that year, where the zero premium plan only provides $1,800. So you're going to have differences where the Medicare Advantage plan, if you need those extra services, ones with premium may provide you more of those extra benefits. So you are getting more for those premiums. The plan deductibles, coinsurance, copayments, they're all going to be different from plan to plan, and they're going to be different from original Medicare. Deductibles are going to be handled differently. Like I said, the coinsurance and copayments can be handled differently as far as being handled on the front end with a lot of point of service copays instead of being billed on the back end. And whereas, for example, with the way a plan deductible is handled differently with original Medicare, let's look at the Part A hospital deductible. with a Part A hospital deductible, it's around $1,400, a little bit more than $1,400, but you would pay that for that first benefit period for your hospital stays, and that deductible would be billed in one big chunk. The way that's handled a little bit differently in Medicare Advantage is a lot of times it's spread out between a certain amount of days. So you may have a set rate that you pay per day for the first several days. For example, a plan may require if you get hospitalized, you will have a set copay of $325 for days 1 through 5. But then during that benefit, after days 1 through 5, days 6 through 90 are at a zero copay. And essentially what they're doing with that set copay there is they're addressing that Part A deductible. So that's probably one of the best examples on how the deductibles are handled differently between original Medicare and Medicare Advantage. Now, when it comes to Medicare Advantage, we are put into those networks. So we may have to pay a higher amount if we go out of network, especially with HMOs that we'll talk about here in a minute. They have that very strict network of doctors and providers, and they don't really allow us to go out of network. So we would be a lot more out of pocket. Now, most Medicare Advantage plans, they will have set out-of-pocket spending limits, whereas original Medicare doesn't. So what this just means is that they will set a out-of-pocket limit amount where if we are out of pocket that amount in any given year, then we wouldn't pay any more out of pocket the rest of that year. For example, let's say that the plan that we're currently on has a $5,700 out-of-pocket limit. If our medical expenses, what we're having to pay at any point during the year, reaches that $5,700 amount, then we would have a zero coinsurance the rest of this year. So we wouldn't pay any more the rest of this year until that calendar turns. So it's a protection in place that allows us to basically not go bankrupt if something catastrophic happens and we have a whole bunch of expenses all at once. It's that protection saying, this is the maximum amount of money that you can be out of pocket per year. So who can join a Medicare Advantage plan? We're going to talk about eligibility. To be eligible for a Medicare Advantage plan, you must, one, be enrolled with Medicare Part A and Medicare Part B. That's not optional. You do have to be enrolled in both parts. You do have to live in the plan service area. So what does a service area mean? The service area is just the area in which that plan is allowed to be sold to new customers. Don't get that confused with network area. Network area is the area in which that plan is going to work or be accepted. Service area is a little bit different. Service area, like I said, it's the area in which that plan is able to be sold. And it can vary from county to county. You also must be a United States citizen or lawfully present in the U.S. to be eligible for the plan, and you must not be incarcerated. So you can't be eligible for a Medicare Advantage plan if you're in jail. To join, you must also provide necessary information. So you have to provide information to that specific company to the best of your ability, not provide any misinformation or dishonest information. You must follow all the plan's rules, so just making sure you're going by all their terms and services. And you can only belong to one plan at a time. So you cannot be receiving benefits from two companies at once in regards to Medicare Advantage. That's illegal. So you just can't we can't sign up for multiple companies at once. When it comes to Medicare Advantage and end-stage renal disease, in the past, most people are ineligible for Medicare Advantage if they've been diagnosed with end-stage renal disease. There have been exceptions in the past when it comes to transitioning from one parent organization or within the parent organization to another plan. Sometimes they'll make exceptions if we've been a long time customer with that company. If there's no breaking coverage and we meet all the other enrollment requirements, they may make exceptions there. Now, in the past, Medicare Advantage would be an automatic denial if we had end-stage renal disease. They are making steps to change that. I believe as early as 2021, Medicare Advantage are going to start coming out with some plans that will specifically be designed for end-stage renal disease patients. So we are making some headway there as far as being able to get benefits specifically for end-stage renal disease patients. So right now, Medicare Advantage isn't really a great option for those diagnosed with ESRD, but that may be a better option going forward when we have more plans coming out to specifically address those needs. Now, with someone diagnosed with ESRD, if they do receive a successful kidney transplant and no longer require dialysis, then they're not considered to have ESRD anymore for Medicare eligibility purposes. So if they do come in to Medicare and they've had a successful transplant, then that ESRD tag is not going to keep them from being eligible. And vice versa. They wouldn't be eligible in the future for plans specifically for ESRD. It's one of those situations that if you've had a successful transplant in Medicare's eyes, you don't have ESRD anymore because that issue has been treated, and now you have and now that illness has been cured with the transplant. So it just changes the way eligibility works in that situation. So when can you join or switch plans? The first enrollment period you get is your initial enrollment period. It works exactly like the enrollment period for any other type of Medicare. So when you first come into Medicare, you get that initial enrollment period. It lasts 7 months. It starts the 3 months before your month of eligibility, goes the month of eligibility, and then the last 3 months after. And the way that the coverage works is if you enroll any time within that 3 months before, your coverage will start the first day of that month of eligibility. If you wait and enroll in that month of eligibility, then it will just go into effect the first day of that following month. If you wait for 3 months after, it'll be the first month after the month that you apply, so it can skip a month. So if we want to avoid delay in coverage, we always encourage people to enroll either in that 3 months before or in that month of eligibility. But you can enroll in any plan during that time and avoid penalty. So talking about the Medicare Advantage open enrollment period, that has been reinstated fairly newly. It was reinstated back in January 1st of 2019. It had been in place several years before, but they had taken it away, and they had just reinstated it back in 2019. And so what Medicare Advantage open enrollment period, it is designed for people who are already on a Medicare Advantage plan. It's going to go from January 1st to March 31st every year. If you enroll anytime during that period of time, the coverage is going to begin the first day of the next month. So if we enrolled in January, then the plan would begin in February. If we enroll in February, it'd begin in March, and so on and so forth. It's a 3-month period that we can switch our Medicare Advantage plans. So if we have a Medicare Advantage plan, we can switch to another plan, whether it has a prescription drug coverage or not. We can mix and match there, switch to any type of Medicare Advantage plan that we're eligible for during that time. Or we can drop that Medicare Advantage plan and return back to original Medicare, and of course enroll in a Medicare Part D plan that would be compatible with original Medicare during that time. You won't necessarily have a guaranteed issue right for Medigap policy, so someone going back to original Medicare that's wanting to pick up a supplemental, they could be subject to medical questioning or medical underwriting, going back to original Medicare and picking up a supplemental there. Now, the one stipulation when it comes to this Medicare Advantage open enrollment period is that you have to be in a Medicare Advantage plan to participate. So there's no exceptions. So you have to be in a Medicare Advantage plan on January 1st to use this enrollment period. You cannot participate if you're on original Medicare. So with any type of Medicare, you will have certain special enrollment periods for life events or other things that happen, whereas you might not fit into the other standard enrollment periods. Some of the special enrollment periods that you may receive in the future, if you permanently move out of your planned service area, so if you move physical addresses, you may be moving out of that planned service area where it's able to be sold. So if that happens, you are entitled to a special enrollment period to be able to switch to a plan in that planned service area. That way, you're able to move to a plan that you know is going to work, where it's able to be sold, and it's going to work in the area in which you're moving to. If you lose other credible prescription drug coverage, you would be entitled to the special enrollment period. So what's credible prescription coverage? That is just any active employer insurance, VA coverage, anything that Medicare deems credible prescription drug coverage. If you lost that coverage, you would be entitled to a special enrollment period to be able to enroll in a plan. Typically, your most common is going to be retiree coverage, active employer coverage, and VA benefits are probably the three most common that you're going to see in those scenarios. Another way that you could get a special enrollment period is if you weren't adequately informed your other coverage other coverage was not credible, or it was reduced and no longer credible. So this is a situation where if a representative of a company or your previous plan misinformed you in any way, so it has to be a representative of that company. It can't be a situation where your neighbor told you incorrectly. It has to be a situation where a actual representative of a company or a institution told you incorrectly, and you were kind of stuck in a place of not being able to get coverage because of that. Usually in those situations, to get a special enrollment period, what we have to do is we have to file in a Medicare appeal for that special enrollment period. So what we do is we fill out a Medicare appeal, send it to Medicare's contractor, and they would do a review based on us getting inadequate information from a representative of the insurance institution, or sometimes even a Medicare plan that they provided misinformation and caused us to miss our enrollment periods there, or not be able to take advantage of those periods to switch. So what we would do there is we'd file an appeal to try to get that special enrollment period. So another way that you would get a special enrollment period is if you enter, live in, or leave a long-term care facility, you're eligible for that special enrollment period. So anybody that's going into a long-term care facility like a nursing home or assisted living, anything like that, then you do have a special enrollment period when you enter and when you leave, because sometimes uh, certain plans may not work out at a certain facility and they may need you to switch. So you may be able to switch upon entering to that facility to a plan that's going to work best. And then when you leave, you can switch back to the plan that's going to work best for you when you're going to your other doctors um, outside of the facility. So you do have that special enrollment the entire time that you're in that long-term care facility. You may have a special enrollment period if you qualify for the extra help program. Once again, the assistance programs will be covered in a later segment, but Extra Help is a program that's provided by Social Security. It's also known as LIS, or Low Income Subsidy, and what it does is it's a program to subsidize our prescription drug costs and provide assistance for our premiums and those drug costs themselves. And one of the benefits that Extra Help provides is that it gives us a continuous special enrollment period to be able to switch. And so anytime during the year, we would be able to switch our plan if our coverage wasn't providing everything that we needed. Now, this special enrollment period has been reduced from the way that it used to be. In the past, anybody on Extra Help could basically change anytime. As long as they were eligible for that specific plan, they could change at any time during the year. That has changed a little bit due to systematic abuse and things like that. But the way that they changed it is anybody on Extra Help, they can still change any time during the year, but it's limited to once every quarter. You can change anytime during that quarter, but it can only be once per quarter. So it's going to be January from March, you can change once. From April to June, you can change once, so on and so forth. So that continuous special enrollment period has changed in the last couple of years, but it's still accessible for people on Extra Help that need to use it. If you belong to a state pharmaceutical assistance program, you can be eligible for a special enrollment period as well. You don't see those too often here, but you might see those pop up in other states, and eventually you might see those pop up here too. So if you see any of those state pharmaceutical assistance programs, come along. Anybody who are on those will be entitled to a special enrollment period to be able to switch if they need to switch to another coverage. Or there's always going to be exceptional circumstances, in special situations where there might not be a black and white answer, and it might be a specialized situation. They may be entitled to a special enrollment period, just like the situations where someone wasn't informed of their coverage, was misled in any way. Usually those type of situations are going to be awarded an appeal. So when it comes to Medicare Advantage plans, Medicare is going to rate all of the plans being sold on the market. They're going to do a standard rating from 0 stars all the way up to 5 stars. And we do come across situations where there might be a low performing plan. As far as I know, in my area anyway, we haven't seen any low performing plans in the last couple of years, but it's something that can happen. And what a low performing plan is if that plan has had a star rating of below 3 stars for 3 years. So they haven't been able to break that 3-star mark for the last 3 years. When that happens, they are tagged with this little icon that has the triangle with the exclamation mark in it. And that's just an indicator that they have been tagged as a low performance plan. And so if we're in a situation where we get enrolled in a plan that is tagged as a low performing plan, we may be able to change that to get out of that low performing plan. Plans may not attempt to discredit their low performance status by showcasing a separate higher rating. So they can't hide from that star rating. If Medicare tags them as a low performing plan, that icon is going to show up and it's going to be very obvious that that rating exists. So talking about the 5-star special enrollment period, we talked about low performing plans. Now we're going to talk about the 5-star plans. These are the plans that have earned their 5 stars and have the highest rating that can be provided. You can enroll in a 5-star Medicare Advantage plan once every year. And this is a special enrollment period that you get because they allow you to obtain that 5-star plan once every year if there's a plan on the market that is rated 5 stars. So you can do this at any point of the year. It doesn't have to be at the first of the year. It doesn't have to be during the enrollment periods. It can be once every year, but you can only do it once. And of course, if you switch to that 5-star plan, then that new plan would just start the first of the month after it was enrolled, so the first day of the next month. The plan ratings, they're always granted on a calendar basis, and that always happens in coordination to the open enrollment period that happens every October between October 15th through December 7th. Usually the plan details starts getting updated October 1st and then usually gets finalized by October 15th of the annual enrollment period start. And so that's when those new ratings will start coming out for those plans. And of course, you can use that Medicare Plan Finder tool to view those ratings. Every single plan is going to have a rating there, so you can look at that overall plan rating and kind of figure out how those plans are being rated, if there's 5-star plans, if there's low performing plans. All of that information is going to be available for you to see. I believe later on in the day we're going to have a demo of kind of how Plan Finder works. The Medicare Advantage trial rights and Medigap. So when it comes to Medicare Advantage, you do have special rights for when you join a Medicare Advantage plan for the very first time when you first become eligible. And what I mean by that is for the first 12 months of your eligibility, if you start with a Medicare Advantage plan upon becoming eligible for Medicare at 65, you get what's called a 12-month trial right. And basically what happens is you have the ability to switch back or change your coverage anytime during that 12 months. So basically you get 12 months to figure out whether that coverage is doing everything that you need it to or not. So for example, let's say that you get 6 months in and you decide that this Medicare Advantage plan may not be providing everything that you needed to, and you want to go back to original Medicare, pick up a supplemental. You would be able to do that any time of the year during that 12-month trial period, and you would have your Medigap guaranteed issue rights to go to a company without them being able to ask you medical questions. Now, this only happens for your very first Medicare Advantage plan. Once you've used this trial period up, you do not get it again. So later on, if you wait past that 12 months or switch to another Medicare Advantage plan, that trial period no longer exists. So after that point, if you decide to switch back to original Medicare, you may be subject to the medical underwriting when it comes to Medigap. You would not be entitled to that guaranteed issue rights any longer. So it'd be very important, if we were considering to switch back to original Medicare, to do it within that trial right, because we know we would get those guaranteed issue rights to move into a Medigap plan with 100% acceptance. So now we're going to talk about the network types when it comes to the Medicare Advantage plans. In my opinion, this is the very most important part of Medicare Advantage plans, because this is this is what can make or break a coverage for somebody, because obviously people are going to have specific doctors and providers that they need to go to. So we need to make sure that that particular plan is going to be accepted where they need to go, because if it's not, it can cause some problems. They may have to pay out of pocket with the doctor that they need to go to, or they may have to completely switch to a doctor that they're less familiar with if it's not within that service network, or not within, or if they just straight up don't accept that plan. So we want to make sure we get that right when it comes to counseling our clients on those networks. Now, the first network type is a health maintenance organization, or you'll mostly hear it by its shorthand, which is HMO. This is the network type where we have to fit within a specific network of doctors and providers. It's the strict one. It doesn't really allow us to go outside of the network. They just don't really pay for out of network. If we went out of network, most of the time we would be 100% out of pocket. So it's very important with an HMO that we're staying within that network. In most cases, all of these HMO plans do have the prescription drug coverage built into it. You're going to see that with any Medicare Advantage plan. Most of them are going to have the drug coverage built in. In most cases, you do have to declare a primary care doctor. And sometimes they can even be included on the card. So in most cases here, you do have to declare primary care. If not, one will actually be assigned to you within that plan's network. In most cases with an HMO, you do have to have a referral to a specialist. And so they don't really let you seek out specialists on your own. You would need that referral through the program itself. Make sure they're getting a specialist that is covering that plan's network, being able to accept that plan and get that coverage there. A couple of the other things that you need to know about the HMO plan type is if your doctor or other healthcare provider leaves the plan, your plan does have to notify you. So they do have to let you know if that plan, opts out of that contract or moves into a different network. And they do have to allow you to choose another plan doctor. So if your current doctor leaves that plan, you wouldn't be able to follow them in a HMO, because the HMO doesn't cover out of network, right? But they do have to allow you to choose another plan doctor within that network. If you get healthcare outside the plan's network, like I said before, you may have to pay the full cost of that bill. And it's important that you follow the plan rules. For example, the plan may require prior approval or pre-certification for certain procedures. Where you see that the most is like lab tests, surgeries and procedures, x-rays, things like that may cost a lot of money, where they want to do that pre-approval or prepayment for those services. So sometimes that can create some delay when it comes to that, because it may take a couple days for it to process, get that pre-approval in, so you can go ahead and get that service taken care of. So that might be one instance where the HMO requires that, and you may have to wait a couple days before you get that procedure done. So that's an example of some of the things you may have to follow in an HMO. HMOs can be really great, but they do have the strictest rules, and you have to follow by all those rules and kind of stay within that network. The next one we're going to talk about here is a preferred provider organization, or a PPO plan type. With PPOs, they're going to be a lot more lenient when it comes to networks as far as doctors and providers go. Most of the time, you should be able to go to most of the places in your area. They're going to still have a set network of doctors and providers, but they are going to more than likely have coverage for out of network. Now, if we do go out of network, they may not cover all of their main co-insurance, so they may not cover all of that 80%, but they are going to have coverage for out of network providers. So you might see like a 50% coverage for out of network providers. So it's usually at a higher cost, but they do still have coverage for out of network, whereas the HMO doesn't. Just like HMOs, most of the PPO plans are going to have the prescription drug coverage built into the plan itself. So you wouldn't have to worry about picking up a separate drug coverage with those plans, as long as your plan had that coverage built into it. Now, talking about the drug coverage for both of these plan types, it's not different as far as the way that it works. So what we get as far as the prescription drug coverage goes is fixed based on that plan. So each plan is going to have a select formulary and select pharmacy network when it comes to pricing and covering certain medications. So you just want to make sure that particular plan has the drug coverage that you need for your medication list. Now, with a PPO, you do not typically have to select a primary care doctor. Sometimes you can list a primary care doctor on a PPO if you want to, but oftentimes they do not require you to declare a PCP or a primary care physician. Do you need a referral to see a specialist? In most cases, you don't. There are going to be specialized cases where they may need to send you out a network, or a exigent circumstances. But in most cases, you will not need to see a referral. So anybody who accepts that plan, you'd be able to go to any specialist within that network. What else do you need to know about the PPO plan type? They aren't the same as original Medicare or Medigap's. So they are a Medicare Advantage plan. Let's not get that mistaken with original Medicare or Medigap. It's still going to follow the same rules as Medicare Advantage plans. It's going to pay up to that 80% that Medicare pays, and it's going to have those upfront co-payments or co-insurance like Medicare Advantage plans are set up. So it's different from original Medicare in those aspects. A Medicare PPO usually offers extra benefits other than original Medicare. And so we talked about that earlier. They may offer some version of dental, vision, hearing, transportation benefits, telehealth benefits, fitness benefits, additional benefits that would not be addressed in the original Medicare package. So now we're going to talk about Medicare special needs plans, or they're often referred to as SNP plans. What these plans are designed for is they're designed for people who are eligible for both Medicare and Medicaid. Often term people use when it comes to patients who are both Medicare and Medicaid eligible, they use the term full dual. So if you hear full dual, DUAL, then you know that they have both Medicare and Medicaid. And these are what these plans are designed for, these special needs plans. What they are is they're specialized Medicare Advantage plans that coordinate both your Medicare and your Medicaid coverages. So they're just coordinating both of those benefits and providing you with a little bit more benefits than you may even get in a standard Medicare Advantage plan, because it's providing, or it's baking that Medicaid coverage into your Medicare coverage as well, to provide that special help. All S&P plans do provide prescription drug coverage. They're all required to, so it's going to be built into the plan. When it comes to networks, special needs plans, they're going to work exactly like HMOs. So they are going to be strict when it comes to doctor providers. You're going to have referrals. You're going to have to make sure that doctor or provider accepts that specific plan. So it's going to be a lot more strict than your PPOs. It's going to be built exactly like an HMO, where you got to be really careful with that network type. So it's very important with those plans to make sure that all of their providers are going to accept that plan and work with what they need to do. In most cases, just like an HMO, you do need to be referred to a specialist on these special needs plans. There are going to be certain services where you don't need referrals, like if you get like annual screenings, like your screening mammogram, which is a base Part B coverage, you wouldn't need a referral for that, but for your more specialized things, they would require a referral within the plan. When it comes to the special needs plans themselves, they are going to be limited to certain groups of people. Some of the restrictions that they're going to have is, number one, those people must be living in a certain institution like a nursing home or who require nursing care at home. So what they're meaning by this point number one is that first requirement is for people in a program called Choices. Choices, long story short, there is a TennCare program that's designed specifically for people needing facility care or nursing level care in the home. So they're getting that help based on that eligibility. And so that's just what they're meaning by that. They're people within that Choices program that's receiving that facility care or that nursing home level care at home and are being provided that TennCare help. Number two, those are eligible for Medicare and Medicaid. So this is everybody else that's eligible for the Tennessee Medicaid or TennCare program. Number three, those with specific chronic or disabling conditions. So someone who has a specific health or chronic condition that has led to their disability, there may be a specialized plan for them. Plans may further limit membership. So what they mean by that is they don't have, not every plan has to include all three of those requirements. They may say we're only going to take Choices patients, with point number one, or we may only take Medicaid, so 1 and 2. Or there may be a specific plan that's designed for somebody with a specific chronic or disabling condition, and they don't accept the Medicaid requirements. So you may have companies that even do all three, but they do have the ability to limit membership to one or more criteria. Plans are going to coordinate all of your services and providers. So that's what they mean by coordinating both your Medicare and Medicaid. They're going to coordinate that coverage to make sure that both your Medicare and Medicaid are paying for that provider as long as they're in network. The plan should make sure that providers accept, So you just have to be really careful to make sure that the provider that you're going to accepts Medicaid if you have both Medicare and Medicaid. So if that provider that you're going to says that they don't accept Medicaid, then that special needs plan is likely not to work there. They do have to have the ability to accept both Medicare and Medicaid for those type of plans to work. The plan should make sure that the plan's providers serve people where you live, if you live in an institution. So why this is important is if you're living in a specific area and you get moved to a facility that is outside of that area and are now a resident of that facility, you have to make sure that the plan that you move to or the plan that you're on is within that service area for that institution. And, just to recap, service area is the area in which that plan can be sold. So we just have to make sure that that plan is within that service area and is able to serve you where that institution is located. It doesn't go by where you live anymore. It goes by where that facility is located. So you just have to be really careful in that regard. And that is the basics when it comes to Medicare Advantage plans. So at this time, I will open up to any questions.
Tyler, we had a couple of questions come in here. The first question is, are there cost increases or penalties if you do not sign up during the initial enrollment? And if you do not sign up initially, are you able to sign up for a Medicare Advantage plan later?
Yes. So you would be subject to the typical penalties that you would receive with Part A and Part B, along with Part D, as in dog, for Medicare, if you do not enroll. So typically how this occurs is if you become eligible for Medicare and you don't enroll in Part B or Part D, you would be subject to those penalties later on, even if you do enroll in a Medicare Advantage plan, because you're still receiving Medicare Part B and Part D coverage. So if you did accrue any penalties during the time, if you didn't enroll when you first become eligible, you would be subject to the penalties that you incurred by not enrolling. Now, if you don't enroll in a Medicare Advantage plan now, you do have the ability to enroll later. The way that you would do that is you'd use the annual enrollment period, and that period goes from October 15th through December 7th every year. If you do make any changes during that time, then your new plan would go in effect January 1st. So when you first come in and eligible for Medicare, if you don't enroll in a Medicare Advantage plan now, you do have the ability to enroll in one later during those enrollment periods. Now, one thing to know is if you do enroll later, there is these Medicare Advantage plans will have the ability to look at your medical history. So this is something that hasn't been as prevalent in the past, but going forward, Medicare Advantage plans are going to have the ability to deny in some cases. So if you do enroll later on, one thing to know is you may be subject to some medical questioning there. But typically you will be able to enroll in a Medicare Advantage plan later on down the line. You just have to wait for those Medicare enrollment periods to do so.
And you had mentioned that you might not be able to get on a Medicare Advantage plan if you have an end-stage renal disease. But what if you develop it after you've been on a Medicare Advantage plan for years? Will they or do they kick you off of that plan?
Typically, once you're already on a plan, you're not going to see plans kick you off. That's a protection that Medicare is going to give you. It works the same way if you're on original Medicare with the supplemental. When you're already on the plan, they're not going to kick you off when you develop a pre-existing condition, because they couldn't ask you about those pre-existing conditions when you enrolled anyway. And the same thing is going to work in Medicare Advantage, where if you've already been accepted to that plan, as long as you're going to a provider for that condition that's covered within the network, they are going to pay for those services because you were already on that plan. So they are going to provide coverage there. They're not going to deny you coverage for a condition that you develop after you're already enrolled in the plan.
Awesome. And are diabetes and high blood pressure considered as chronic or disabling conditions?
Typically, you won't see that with high blood pressure. Diabetes, it would be in situations where that was the main diagnosis for you being disabled. Typically, the prerequisites you're going to see with those special needs plans when it comes to chronic or disabling conditions is these are the conditions that led to you being disabled. for you being eligible for Medicare based on disability. So I can make an argument for diabetes there, but it would have to be the main diagnosis for that, for you being considered disabled and getting eligibility based on disability. So it's one of those where you're going to see those major conditions like degenerative disorders, and things like that that would be chronic and disabling conditions that led to disability. So diabetes is possible there, but it would have to be that main diagnosis there that led to that disabling condition.
And for people that do qualify for a special needs plan under chronic or disabling conditions, do they still have to qualify income-wise like they do with Medicaid?
They may not be able, or they may, sorry, let me start that over. They may not have to fall within those same income limits as Medicaid, because they're not actually receiving Medicaid benefits, necessarily. Now, you can have both. You can be receiving Tennessee Medicaid and have a chronic or disabling condition, but they're not inclusive or exclusive of each other. So if someone who doesn't have Medicaid, they may still have a chronic or disabling condition, so you wouldn't have to fit within that income parameter of Tennessee Medicaid, but you wouldn't be eligible for any of these special needs plans that had that criteria of being in the Tennessee Medicaid program. You would only be eligible for the plans that specifically targeted patients with chronic or disabling conditions, and with that being the only criteria.
Understood. What aspects determine low-performing plans?
Yeah, so with the star ratings, Medicare is going to look at several different factors. They're going to look at enrollment process, enrollment efficiency, how many people are able to get enrolled, how many enrollment problems were occurring. They're going to look at customer satisfaction. They're going to do the ratings based on subordinates with the plan when it comes to Medicare dealing with them, how that synergy is working with Medicare. So they're going by based on all these different factors. And so their rating is going to be based on those things. So typically plans with higher ratings are going to be scoring well in all aspects, where plans with average ratings may be doing really well in one aspect and maybe not so well in another. And then low performing plans are just not going to be doing well in all aspects.
And how often does Medicare review low performing plans?
Every year. So they come out with those ratings every year for the annual enrollment period, between October 15th and December 7th. So they're going to do that on a yearly basis.
Perfect. Are there any plans on the market that are not published on the list for Tennessee?
No. So all of the plans that are Medicare approved, and to be on the market, you do have to be Medicare approved. And so every single Medicare Advantage plan that is on the market is going to be available to view on Medicare's Plan Finder tool on the Medicare.gov website. So any plan that is available is going to be able to be viewed on that Plan Finder tool.
Great. And does having a guaranteed issue rights period mean medical history can't be applied while exercising this enrollment right?
Yes. So it's going to work very similarly to the Medigap guaranteed issue rights when you first come into Medicare. So you are going to have that eligibility to enroll in a Medicare Advantage plan without medical history being taken into account when you first become eligible for Medicare. But later on down the line, if you're outside of those guaranteed issue periods, later on if you're saying, 2 or 3 years later, we use the Medicare annual enrollment period to enroll in a Medicare Advantage plan, we may be subject to medical questioning, maybe not as extensive or rigorous as a Medigap policy, but now they will have the ability to look at medical history going forward. But when we first come into Medicare, we're going to have a lot of those same protections that we do with original Medicare.
And the next question is, as critical as healthcare is, why are low-performing plans still sold currently and in the future?
Yeah, so my answer to that would be they may still be following all of Medicare's requirements to be a plan that's sold on the market. They may just be scraping by. Even though they're a low-performing plan, they are still meeting those minimal requirements to be a plan sold on the market. Now, typically, you do see where Medicare will freeze certain plans, where if they are just not doing what they're supposed to, or they're just extremely low performing and they're messing up a lot of enrollments, or they're not providing coverage for certain things that they came out with the information that they were going to. If there's things like that that's just happening, that's really bad for that plan, then Medicare may freeze that plan during the year. And what I mean by that is the people that have already enrolled that plan can stay on the plan, but now they've frozen that plan to where new customers are not able to enroll in that plan the rest of that year. And so sometimes you will see that happening with low performing plans. And that's more likely if they're on the verge of Medicare basically saying, we're not going to have you be a plan on the market anymore. But as long as the plan itself is following all of Medicare's terms and services, and eligibility to be a plan that's sold on the market, typically you will see them stay on the market unless Medicare issues sanctions against them.
And do HMOs offer no coverage outside of their network? Is that generally how they operate?
Yeah, exactly. So HMOs are the strict network type. You have to have that certain provider network where you have to stay within that network and make sure that they accept that plan. Typically, they do not pay for out of network. So if you went to a provider that was outside that network, that patient could be subject to all of the out-of-pocket costs there.
Great. And could you explain the difference between service area and network when it pertains to Medicare Advantage plans?
Yeah, so the main thing to know about service area is it's the area in which that plan can be sold to new customers. So it's not the area in which the plan works, it's just the area in which the plan can be sold. And that can vary from county to county. Our area, the Upper Cumberland, is covered by 14 counties. We have seen some plans in the past where they cover 4 or 5 of our counties and don't cover any of our other counties, maybe the more eastern counties. So you're going to see that where they're going to sell plans in certain areas and not sell in other areas, and that's just known as service area, the area in which they can be sold. Network area is a little bit different. Think of network area as the area in which that plan works. So it'll be areas where that plan is able to be accepted, where it's able for providers to sign that contract and opt into that plan.
Awesome. And what does the process look like if you choose to disenroll from a Medicare Advantage plan and switch back to traditional Medicare, such as during the Medigap trial right period?
Yeah, so typically what you would want to do during your trial right period, if you wanted to switch back to original Medicare, first and foremost, the one thing that we would need to do is if we were wanting to get a Medigap policy, we would want to start contacting Medigap companies. We want to make sure that we're able to get coverage for that 20%. If we're wanting a 20% policy to cover whatever Medicare doesn't. So we would contact those companies first, and we could go ahead and be getting that in place. Next, what we would want to do there is we would want to find a Part D prescription drug plan that was going to be compatible with original Medicare and was going to cover all the medications that we needed. Because if we switch back to original Medicare, we would need a Medicare drug plan that cover our medications. So we would find a Medicare Part D plan, request enrollment for that plan. And from that point forward, that's when we can notify our Medicare Advantage plan that we're going to be disenrolling. We don't want to do that before. We don't want to disenroll before we start trying to get these other coverages in place, because sometimes that can mess with our enrollment periods. We might accidentally use up our enrollment by disenrolling in that Medicare Advantage plan. So we want to be tactical and make sure that we're lining up our original Medicare package before we make that move. So we would want to enroll in that Medicare Part D plan prior to disenrolling in the Medicare Advantage plan.
So if we're understanding correctly, we should, if we're trying to switch from a Medicare Advantage plan, rather than calling that Medicare Advantage plan and disenrolling, we should enroll into the prescription drug plan and allow Medicare to disenroll us from our previous plan themselves.
That's exactly right. So if you enroll through the Medicare.gov website using their Plan Finder tool when it comes to the prescription drug plan, they will actually handle the enrollments electronically. And so once that enrollment for Part D is processed, they will actually send a termination notice to the Medicare Advantage plan, because it's all connected through Medicare. There is no need to call the Medicare Advantage plan and disenroll before we want to make those changes, because that can mess with our enrollment periods.
Excellent. And if a person does not want a drug plan when they're switching off of a Medicare Advantage plan to regular Medicare, do they have that ability to just not select a drug plan? And if they do make that choice, what are the consequences of that?
Yeah, so prescription drug plan coverage is considered optional. You don't have to enroll in it to go back to original Medicare. But there are some consequences there. If you don't have any other type of credible drug coverage, like a retiree plan or a VA benefits or active employer coverage within the household, then if you don't have any other type of drug coverage, you would accrue a penalty. It's the same penalty that you accrue if you don't get into drug coverage upon first enrolling into Medicare. And the way that penalty would work is it's equal to 1% per month of that national average premium every month that you go without coverage. And so the price you would have to pay there is, if you ever did go to prescription drug coverage, then whatever penalty you accrued there would be tacked on to the premium that you enrolled in with your Medicare prescription drug plan. So you can technically go without a plan, but there would be a penalty to pay if you ever got back on Medicare Part D prescription drug coverage.
All right, excellent, Tyler. That is the end of the questions. Thank you very much for the presentation. I'm just going to grab the record here really quickly.
Good morning, everybody. Thank you, Ryan. Yeah, my name is Loni Hitchcock, and I'm with the Senior Medicare Patrol. And so I'm going to be talking to you about the Senior Medicare Patrol and what we do. My office is actually in Cookeville, Tennessee, but I do cover the whole state of Tennessee. I am the program coordinator for the state. Here is my contact information if you ever need me. I do have a toll-free number. It's 1-866-836-7677. So, of course, why Medicare started the Senior Medicare Patrol is because Medicare loses billions of dollars every year due to fraud, waste, and abuse. I know they've been estimated, like last year, Medicare lost $60 billion due to fraud, waste, and abuse. So, of course, SMP's mission is to empower and assist Medicare beneficiaries, their families, and caregivers to prevent, detect, and report healthcare fraud, errors, and abuse through outreach, counseling, and education.
Loni, people are concerned. Are you trying to share your screen?
Did I not?
No,
Okay, sorry. Let me go back. Sorry. I thought I did.
You're all right.
There we go.
There we go.
Okay, now sorry about that. Now there we go. Okay. So here's my contact information. There's my email, my office numbers, my fax number, so you can get in contact with me any of those ways. So I said why they started SMP is because, and SMP actually stands for Senior Medicare Patrol. Medicare loses billions of dollars every year due to fraud, waste, and abuse. So, and the SMP's mission is to empower and assist Medicare beneficiaries, their families, and caregivers to prevent, detect, and report healthcare fraud, errors, and abuse through outreach, counseling, and education. So how can seniors protect or prevent fraud? They can actually prevent fraud by protecting their Medicare number. They need to treat their Medicare number like it's a credit card. And now everyone should have a new Medicare number that is no longer based on either their Social Security number or someone else's Social Security number. It is now an 11-digit combination of letters and numbers. Of course, even with this new Medicare number not being Social Security number based, it is still very important because scammers are still getting these numbers from the beneficiaries and billing stuff to Medicare. There's several different scams going on right now that I'll talk about later. So it's very important for seniors to prevent fraud by protecting their Medicare number. Do not give it out to anybody in a phone call that they receive, especially if they have not called that person first and left a message or something for a return call. I tell seniors all the time, one, Medicare does not call people. Medicare only usually communicates by mail. Social Security doesn't call people. None of the federal agencies usually call people unless they've called that agency first and left a message for a return call. So that's how, one, they can prevent fraud. So how can seniors actually detect fraud? They can actually detect fraud, one, by, keeping good records. When did they go to the doctor? What did the doctor order any tests? What day they went to the doctor? What did the doctor do? Keep up with those. Another thing is reading their Medicare summary notices or explanation of benefits. Those are two different types of statements. The Medicare summary notices are the notices that if they're on original Medicare that they receive from Medicare. The explanation of benefits or benefits explanation, whatever the Advantage plans call that, or the Part D plans, those are the statements that come from their Advantage plans or the Part D plans. And so if they can read those and, compare those with their notes and stuff to make sure that, Medicare hasn't paid for a service that they did not receive or something like that, it really comes in handy. Also, I tell beneficiaries, before you ever pay a bill, make sure you have, compared your records, your MSNs, EOBs, and that bill before you ever pay it to make sure this is something you owe. Because your MSNs and your EOBs will tell you if you owe that or not. And especially the ones with the supplements, you have to wait till you get all of those statements in before you can compare the bills. So I tell beneficiaries, please don't pay anything until you actually know for sure that you owe it. And keeping track of things is a really good thing. And I hand out, it's called a personal healthcare journal. I hand these out to seniors when I go do presentations. I hand these out at health fairs. I've even had doctors' offices call me and request them so that they can hand them out to their patients. All of the coordinators in your areas actually have boxes of these. I send these out almost yearly. So if you all need a bunch of these personal healthcare journals, they can actually keep track of their doctor's visits, the medicines that they're on, what happened during that doctor visit. It's a real little handy little tool that they can put in their pocket. It's really not that big. So if you need it, get with your coordinators or your volunteer coordinator in your area, and they can get you some. Or if you want one yourself. So after looking at all that and keeping track and everything, if they do find something on their Medicare summary notice, like a service they didn't receive, service was wrong, they got a regular x-ray instead of an MRI, anything like that, they need to report it. So if they do find something, they need to report it. That's how we can actually stop the fraud, is if it gets reported. Another way that I tell, sometimes coding gets messed up. I tell, beneficiaries, if you can, call your healthcare provider to make sure it's not a mistake. Because, they do make mistakes, number switch or whatever. So I tell them, call your provider, so make sure it wasn't a mistake first. Call the company that, that paid the bill. You can call Medicare, and if those don't work, definitely contact me. And, you all can give them my information, those RAC cards that we hand out, anything, give them my toll-free number, they can call me, or you can, take down the information and email it to me, however it works. The main things that I need if I'm going to do if you're going to do an S&P referral is, I need their name, date of birth, address, phone number, what was the issue, pretty much the who, what, when, where, and why kind of thing. So I need all of that information before I can proceed. So this is why Congress says that seniors are our best front line of defense against these Medicare losses. And it's because a lot of them don't know, like if they do find something, they don't know where to go or where to turn. Or I get several referrals, in a year and saying, well, it's been so long because I didn't know where to go, or things like that. Something that could have been handled early if they'd known about the S&P program. And even seniors, there's a lot of seniors that still don't know about the SHIP program. I hear it several times, a year, especially during open enrollment. I wish I'd known about y'all sooner. Y'all could have saved us so much money. We go hand in hand. I go hand in hand with SHIP. We could have stopped this fraud earlier if we'd known about the S&P program or anything like that. So, or, you could have got my money back, or, you could have helped me not have to pay this bill, or, something like that. It goes hand in hand. So that's why, SHIP and S&P are teamed up, because we are all dealing with Medicare and Medicare issues. So, of course, S&P is a national program. I am grant funded through the Administration for Community Living, ACL for short. So my S&P actually started in '95. They were trying to think what can we do to educate the beneficiaries more on how to prevent fraud. So in '97 they came up with 12 demonstrations. So that's how S&P first started, was 12 demonstrations, and they saved so much money that they went nationwide. So there is now a S&P in every state and territory, just like SHIP. And both SHIP and S&P were both under the Administration for Community Living. Of course, I am grant funded. My grants, my funds actually come from the Healthcare Fraud and Abuse Control Program. That's where my federal grant comes from. So, you know, being a volunteer, there's some things that you know, as an S&P, I need help with. I need help with, you know, disseminating the information. If you're setting up at a health fair, talking to beneficiaries, anything like that, please pass out the S&P information. You know, give them a healthcare journal, anything like that. Next one is, you know, assisting beneficiaries in resolving those issues and complaints. That's what that one-on-one counseling is. And the next role of an S&P is referring suspected cases of fraud, waste, and abuse to the appropriate investigative entities. Now, I am not an investigator, even though that is my background. I am not an investigator for OIG. I just pretty much prepare the case for OIG and I send it on to OIG. But I am not the one that's investigating it. I'm just the information gatherer, pretty much. But there's a lot of boxes that need to be checked off by OIG. For example, we have to know the who, what, when, where, and why. And I have to go into more detail. So it needs to be as detailed as possible in order for the OIG to actually pick up the investigation and go with it. So I have to have a lot of boxes checked for the OIG in order for them to investigate it. Of course, you know, with me having federal funds, I am accountable to, you know, the federal government, ACL, OIG, and the taxpayers. I actually have to do a report to OIG every year. And that's based off of my SERS program, and I'll tell you a little bit about SERS later. Of course, as I have to do a semi-annual report to OIG. You know, my database, which I collect all the information in for S&P, is called SERS, and that's a S&P Information and Reporting System. And luckily, STARS, which is the SHIP information system, and they'll be talking to you about STARS later. STARS and SERS actually can talk to each other, which is a good thing. So there is a checkbox on the STARS system where it says, do you want this information sent to S&P? And, you know, if it's fraud related or, you know, something like that, then yes, you need to check that box to send it to S&P. So that's how I get a lot of my data. It comes from the STAR system over to SERS. So as I was telling you earlier about the OIG report, I have to do an OIG report every year. And this is the team members, all my team members, all your hours that you have worked, all the outreach and education activities that we have done, and any of the complaints that I have done. That's how the OIG gets them, is through my SERS system. OIG has access to my SERS system, and they can go in and pull that report off of my SERS system to start their investigation. So everything gets put in SERS. It didn't happen if it's not in SERS. Like STARS, it didn't happen if it's not in STARS. So my OIG report for 2018, here is my numbers for 2018. I had, you know, we had, oh, this is the national number. Sorry, this is the national numbers for S&P for 2018. We had almost 7,000 active team members. They had over 26,000 group and outreach events. They had over 278,000 individual interactions. Cost avoidance on behalf of Medicare, Medicaid beneficiaries, or others was almost over $602,000. Total savings to beneficiaries was over $27,000. Expected Medicare recoveries was over 15,000, and additional expected Medicare recoveries was over 11 million. So as you can see by our 2018 numbers, SMP does work. So here's the 2018 SMP numbers. For the state, we had 426 active team members. We had over 19,000 team member hours who did like over 830 group and outreach events. We had over 32,000 individual interactions. Cost avoidance on behalf of Medicare was over $8,000. And of course, I didn't have any of the other savings, because in order for me to claim those other savings is that fraudsters actually have to be prosecuted and judgments awarded and things like that. So sometimes that does take time. Sometimes it takes years for us to get any in some of those other categories. So that's why it's very important for us to have as many volunteers as we can, so that we can reach as many beneficiaries that we can. Yeah, it's very hard for us to reach, over 2 million beneficiaries. Without you all's help, it's very hard for us to do what we do. So that's why we, try to get as many volunteers as we can. We thank you all for volunteering, because we couldn't help as many beneficiaries if we didn't have the volunteers. So here's some things that other volunteers have done. Assisting with administration. We've had volunteers do filing and things like that. Distributing information, that's, going out and handing out flyers and things like that, brochures. Staffing exhibits, that's, coming and, sitting with us, doing health fairs and things like that. Helping make group presentations. Sometimes we team up and go talk to senior centers and, anywhere we can talk to people to tell them about the SHIP and SMP program, we do. Of course, the counseling is the one-on-one, and then the handling complex interactions is pretty much what I do, is doing the fraud referrals. Anyone can find SMP. I'm really hard to find, really easy to find. I do have a toll-free number. They can find me on the ACL's website. I'm actually in the Medicare and You handbook. We actually have a SMP resource center where we have a lot of information already on there, like flyers and things like that. So if you all are a volunteer and you want access to my the SMP resource center, you would have to click on this link and go in and set up you an account. Please send me an email to let me know that you're doing that, so that because I have to go in and approve it. So that's, if you want to do that, and it's real handy. Several different tools. There's flyers, brochures. I mean, there's presentations already done. And we contribute. All the SMPs contribute to the the SMP Resource Center. So we're putting all sorts of things in there, all of us. So that pretty much wraps up chapter 1. I'm going to skip the test that I usually do in person. And I'm going to start with some Medicare statements. As I said earlier, there's 2 different types of Medicare statements, or claims tracking statements. You've got the Medicare summary notices, which is the ones for original Medicare, and you've got the explanation of benefits, or whatever that Advantage Plan and prescription drug plan may be calling it. I've seen it different things. I've seen it EOBs. I've seen it benefit summaries. I've seen it called different things, but it's pretty much got the same premise. And what these show is, they show, what healthcare provider billed Medicare, what the amount approved by Medicare, how much Medicare or the Advantage Plan paid, and what the beneficiary may be billed. So that's just pretty much what those statements are, and they pretty much explain the same thing. Some are better easier to read than others. It depends on the Advantage plan. Later, I'm going to be showing you what an actual MSN or Medicare Summary Notice actually looks like. So that's why it's very important for beneficiaries to have these, I think the healthcare journal, so they can keep track of everything. Because one of the things about the MSN, the Medicare Summary Notice, if they do not have a mymedicare.gov account, then they're only receive their Medicare Summary Notice once a quarter. So Medicare only mails that out once a quarter, unless they have a mymedicare.gov account. If they have a mymedicare.gov account, they can actually go in and see their claims in real time. That's for the people that's on original Medicare. Now, the Advantage plan, sometimes you can have those depends on the plan. They can give you access to their area or whatever, and that way you can see your claims in real time on their sites also. So it depends on the plans. So as I said, the mymedicare.gov account, so you can see the claims in real time, and they can check, their deductible status, anything like that. The mymedicare.gov account is really handy, especially if, seniors are, computer savvy and they can actually, work it. Of course, we do have seniors out there that don't even own a computer. So this wouldn't be helpful for them, but these ones that, do have a computer, have internet, I highly recommend them getting a mymedicare.gov account so they don't have to wait so long for them to get their summary notice in the mail. Now, the explanation of benefits, they actually come out most of the time in real time or every month. It depends on the plans. The plans have different ways that they do it. So how do you read a Medicare summary notice? There is two different types of Medicare summary notices. Sometimes they put them on both on the same one. But you'll have your Part A and your Part B. Of course, your Part A, you learned yesterday, was your hospital. Your Part B is your medical insurance. So there's, two different ones. And of course, and I tell this all the time, if someone is in the hospital under outpatient observation, they will not get a Part A because they are not inpatient. They will get, their admission will be under Part B because it's outpatient observation. So just keep that in mind. And there's a lot of seniors out there that I've had to explain to. Just they think because they're admitted that they're in as an inpatient, but they're not. They were there for outpatient observation, and I've had to explain that a lot to seniors or their family members. Just because they were admitted doesn't mean that they were admitted as an inpatient. And that can really mess up some other things, like for bills and especially medications and things like that. So I highly tell beneficiaries, make sure when they're admitting you, if they're admitted, ask, am I being admitted as an inpatient or am I being admitted as outpatient observation? That's the two totally different things. And I even tell family members to ask also. So here's what a Medicare summary notice Part A looks like. It's pretty standard. Has the name, address, part of their it'll have their Medicare number, the date of the notice, and that date of the notice is actually something that they actually need to pay attention to. The claims process between, now that's the dates that the claims were actually processed. Believe it or not, providers have 1 whole year to submit a claim to Medicare for payment. So the claims process between is the date that the provider submits the claim to Medicare and Medicare processes it. So, and providers have 1 whole year to do that. So that's why the claims process between is very important. Another thing to look for is did Medicare approve all the claims? Yes or no? That's over on the right. Because if Medicare, did not approve all the claims and they denied something, which you may have to help a beneficiary file an appeal, depends on why, it was denied. Sometimes it's just a coding error and they can go back to the provider and talk to the provider and say, hey, something's not right. Medicare denied this, and the provider can fix it. They can pull the claim back, correct it, and resubmit it to Medicare. If, most providers are willing to do that. If it's something Medicare denied, sometimes you have to do an appeal in order for Medicare to provide it or pay for it. So, and then on the very first page, it'll list all the service providers, or for example, this Part A1, the hospital that they were in and the dates that they were in the hospital under Part A. Page 2 is a lot of information. If this is a Part A1, the important information to look at on this page, especially if you're dealing with the benefit periods, is your benefit periods, because it will tell you how many days inpatient hospital you have used. Because you remember, you have 90 days, and then once those 90 days are over, you've got, so many days for and I went completely blank, of the carryover days. So that's why it's very important to look at these, the benefit period days. How many have you used? The skilled nursing facility, same thing. How many days of those have you used? So it's really important so you can keep track of these days so that you won't go over. Here's where it gets down to the specifics of who, what, when, and where. So this beneficiary, she was in the hospital as an inpatient because it's a Part A1 from June 18th through June 21st. So that's 4 days was used. Was the claim approved? Yes, it was approved. Any non-covered charges? There was not any. Amount Medicare paid. And amount the Medicare beneficiary may owe. So as you can tell, this gets down to the specifics of that. I always tell the beneficiaries, if there is a letter on the right hand side, it says see notes below. If there's a letter there, please read the notes below, because sometimes beneficiaries, it'll say that if you do owe something, it'll say that this deductible was sent to your supplement, or something like that. So there, if it was something denied, it'll tell in the bottom why it was denied. So if you have to help someone file an appeal, if they have their Medicare summary notice, ask them to bring their Medicare summary notice with them. That way you can find the very last page of that Medicare summary notice, because it'll tell you step by step how to file an appeal. So you may have to help a beneficiary file an appeal. And if you don't know how to go about doing that, find the very last page of the summary notice. It'll tell you. And I made reference to that the date that the notice was mailed, and it's because that they have to submit an appeal by a certain date, and it's usually 120 days from the date that notice was mailed. So as you can see, the date that Medicare has to receive this appeal by, or this is an example, is January 21st, 2014. So there is a date there. So if it's past that date, Medicare does not have to look at this appeal unless there's some extenuating circumstance which you can prove. For example, this beneficiary's been in a coma this whole time or something like that. Then, if it's past that date, Medicare will not look at it unless there's some type of extenuating circumstance. So if you have to help someone file an appeal, the first thing to do is go through and circle the service or the claim that they disagree with. and then they have to explain in writing why they disagree or why they think that Medicare should pay for this service. Then you have to fill out these blanks, and then include any other information that you can about the appeal. If you can get something from the doctor stating why, you know, Medicare should pay for this, anything would help to go along with it. Next thing I tell, you know, everyone is write the Medicare number on every single sheet of paper. Next is to make a copy of everything that you're going to be sending. And then down at the bottom, this will tell you where you need to mail everything to. So that's why it's very important for you to find the very last page. It'll tell you, it'll take you step by step on how to file an appeal. This one is just a Part B one. As you can see, they are very similar. So, of course, the B one is your medical insurance. It has the same information on it. You know, Medicare number, date of cert, date of notice, claims process between, did Medicare approve all the services, their deductible status, you know, what Medicare, what they may be billed for, then the list of providers. And of course, you know, page 2, this one's a lot of information. Page 3 and beyond is where it gets down to the specifics of, you know, the service. Was it approved? The amount provider charged, the amount Medicare approved, and the amount the beneficiary maybe, you know, the amount Medicare paid, and the maximum that the beneficiary may be billed. So keep in mind, these numbers do look different. You know, the amount provider charge, believe it or not, is a lot different than the amount approved by Medicare. The amount approved by Medicare is a contracted amount that, you know, this doctor has agreed to, that amount Medicare will pay, you know, this is the amount that Medicare approved. Now, the amount Medicare paid is usually that 80% of that amount approved by Medicare. And that maximum may be billed is that 20% that Medicare does not cover. So that's why you can see the differences in those. And of course, you know, if Medicare denied something, you know, read the notes and things like that. So these are pretty, you know, self-explanatory. If you all have any, you know, issues with the Medicare summary notices, you don't understand them, you know, please give me a call or something like that. Send me an email, anything like that. I can look over it to see if I see any discrepancies. And I'm going to skip this test. Medicare rights and protections. I do explain normally during trainings, there are some things that Medicare has come up with to help protect the beneficiaries. And the one that there are 2 things that I usually talk about. One is the advanced beneficiary notice of non-coverage. This is a form that providers are supposed to have beneficiaries sign. That is if the provider knows that Medicare does not cover that service. For example, you know, Medicare usually doesn't cover plastic surgery or something like that. So they will have the beneficiary sign this advance notice of beneficiary notice of non-coverage. It means it's giving the beneficiary the choice. The provider saying, okay, I know Medicare does not cover this. This is how much this service is. Do you want to go ahead and with this service or not? So it gives the beneficiary options, and the beneficiary has to sign it. You know, for example, no, I don't want this service. You know, they have to check, no, I don't want this service. Yes, I know Medicare doesn't cover it. I will be responsible for payment for the service. Or, you know, I know Medicare may not pay for this. Please go ahead and submit it to Medicare anyways. And if Medicare denies it, then I will pay, then I'll be responsible for payment. So that's pretty much what the advance beneficiary notice of non-coverage is. I tell beneficiaries, if a provider gives you one of these, make sure it is filled out. never sign a blank one of these. It has to be filled out. The name of the service, how much it was, and everything. So it has to be filled out. Another form that Medicare had just recently come up with is the MOON, the mandatory outpatient observation notice, which means that they have to give notice to the beneficiary or the family member that the beneficiary is not an inpatient, that they are in the hospital under outpatient observation, and that is called the MOON. So here's some other services or resources if they have any questions. Of course, you know, the SHIP's listed on there. So now I'm going to talk to you a little bit about actually Medicare fraud. We're going to get down to the nitty-gritty about, you know, fraud and abuse. Of course, scam artists, you know, have treated Medicare like it's an automated teller. You know, getting everybody's Medicare numbers and submitting claims to Medicare without, you know, either them not getting the product or them not needing the product. There's several different scams going around right now. So what is the difference between Medicare fraud and abuse? The difference actually is intent. Fraud is intentional and abuse is not. So that's pretty much the difference between those two. And I leave it up to the OIG to determine if it's fraud or if it's abuse. I don't do that. I just still send it to OIG. It's their determination. They make that determination, not me. Of course, Medicare abuse is payment for items or services when there is no legal entitlement to that payment and the provider has not knowingly and intentionally misrepresented the facts. Of course, fraud is knowingly and willfully executing or attempting to execute a scheme or ploy to defraud the Medicare program. So here's some examples of fraud that I'm going to go over, and I'll tell you some examples. Billing for services or supplies not provided. There is scammers calling Medicare beneficiaries right now, claiming to be from Medicare, asking about their pain. And then they're obtaining the beneficiary's Medicare number, and they are billing Medicare for braces, but the beneficiary never receives those braces. So that's one of the scams that's going around. Providing unsolicited supplies, that still goes along with the scammers calling and sending out these braces. The durable medical equipment companies are not supposed to be cold calling beneficiaries to drum up business. That is definitely a no-no. So if you all hear of any of these companies cold calling these beneficiaries, trying to get them to get, you know, diabetic supplies, anything like that. I mean, I've had them call, you know, beneficiaries trying to give them diabetic supplies and they weren't even diabetic. So that's some of the scams that's going around. So please, you know, I need to know about those so I can report those. Misrepresentation. As I said, there's several scams going around right now. You know, scammers are claiming to be from Medicare. I've even had an agent claim that they worked, and this is an independent agent, claimed that they worked for Medicare. Medicare does not employ insurance agents. Prescribing or providing excessive or unnecessary tests. There's that brace scam that's going around where the scammers are getting the information from the beneficiaries. They're selling the beneficiaries' information to the durable medical equipment companies, and the durable medical equipment companies have a doctor signing prescriptions for these unnecessary braces, and that's how this scam is working. So, you know, another one is providing excessive supplies. I get calls about the durable, test strips. I had one beneficiary call and told me that his durable medical equipment company called him and asked him if he needed any test strips. He said, no, I've got plenty. I do not need any more. Yet they still sent him more and charged Medicare for more. So he reported those, and of course I reported that company. Violating the participating provider agreement. Now that is the contract that the provider has with Medicare. And there's several different ways that they can actually violate that. If they try to charge the beneficiary more than that, 20%, as long as they, take Medicare assignments, they cannot do that because they've agreed to take that, only charge, only accept the Medicare agreed amount and only accept the, 20% payment. So, and there's several different ways that they can violate that provider agreement. Another one is balance billing beneficiaries that are either a dual or a QMB. I've actually called Medicare and done several complaints on providers that continually balance billed Medicare beneficiaries who are on QMB or on who is a dual. Offering or receiving kickback bribes in exchange for beneficiaries' Medicare numbers. I said there's, with this brace scam going around, the durable medical equipment companies are actually paying the physicians to write prescriptions for them. So that is a kickback. Another thing, requesting Medicare numbers at educational presentations or in an unsolicited phone call. That's what the scammers do. They try to get the Medicare numbers in these unsolicited phone calls. And that's why I tell beneficiaries, please do not give your information out to these unsolicited phone calls. You do not know who is on the other end or even where they are. I've even had insurance agents, request Medicare numbers at these educational presentations, which they are not allowed to do. That's actually a marketing violation. Another thing is routinely waiving the coinsurance or deductibles. It's actually part of their participating provider agreement that they have to charge those to the beneficiaries. And of course, there is some times where it is not fraud. It's either an error or some other type of situation. And it's because Medicare is so complex. There are so many rules and policies and all sorts of things that Medicare has to go by. So some of the things that I have dealt with that was not fraud is there are some beneficiaries out there that did not know that they have a Part A deductible that they have to meet. There was this one little gentleman, I had to explain to him that the bill that he received from the hospital was his Part A deductible that he had to pay for because he did not have a supplement or anything like that. I've had to explain, what radiologist is, the ones behind the scenes that, they don't see. I've had to explain what those are because there's beneficiaries that don't recognize the name of the radiologist or, something like that. High or duplicate charges on hospital inpatient bills. I tell beneficiaries, get an itemized statement. Get an itemized bill from the hospital if you can, so that you can go through. There, several different charges. If you're inpatient for a long time, it's going to be a big bill. It's going to be a big itemized statement also. Another thing that I've had to explain to beneficiaries is they thought it was a fraud because Medicare didn't pay for the skilled nursing care, or Medicare denied it. And Medicare will deny the skilled nursing if they have not had those 3 midnights inpatient. I had one beneficiary. She was in the hospital for like 5 days, but 2 of those days, or actually I think it may have been 3. But some of those days she was in there under outpatient observation, and then they switched it to inpatient. But she didn't have those 3 midnights to be considered for skilled nursing care. So that's why it's very, very important for them the beneficiary or the family members to communicate with the doctors or the nurses and keep asking, okay, you know, how is she? Is she in under, you know, inpatient observation, or is she inpatient? Just because they're being admitted does not mean that they're being admitted as an inpatient. Of course, I've even had a beneficiary's medical identity stolen. This happened in, was it Memphis, Adrian? I can't remember. I think it was Memphis. Or maybe in Jackson. I can't remember. But I had a Medicare beneficiary's identity stolen. And this other person was using his Medicare number and charging, they were sending claims to Medicare for, you know, services this beneficiary never received. Okay, thank you, Adrian. It was Memphis. Okay. He was getting charged with for all these claims that he had never had. I mean, the other beneficiary that was not him, I mean, he'd had like a heart attack, bypass. I mean, it was crazy. The stuff was being sent on this other beneficiary's actual Medicare number. So this was actually impacting his health record. So it was a mess to get it cleaned up, and I still don't know if it's all been completely cleaned up. And it was because the hospital did not verify that other person's Medicare number. They just believed what the other beneficiary told them. They didn't get a copy of this other beneficiary's Medicare card to confirm that that was what the Medicare number was. So this all fell back onto the hospital that this other beneficiary was admitted to, not the one where his medical identity was stolen. So the hospital actually had to go back and correct everything and send everything to all the other providers that other beneficiary had used, because they had all come off that one Medicare number that other beneficiary had told them it was, even though they did not verify that. So that's why I tell beneficiaries, please, please safeguard your information. Read your MSNs and your EOBs to make sure everything is accurate. Okay, I am almost done. I'm going to go really quickly through some other scams that I've dealt with. These are a little bit more specific. There is always scams targeting Medicare beneficiaries. Right now, the scams that are going around is, one of them is the brace scam, where they're claiming to be from Medicare or whatever. One of them is they're claiming they're from senior health care and asking about their pain. These numbers that they're calling from are spoofed. So you know that it's a scammer. Medicare does not call and ask you about your pain. They've got your medical records. They can look that up. They don't have to call. But what this is they're pushing braces. The scammers will get the Medicare beneficiary's number. They'll sell it to the durable medical equipment companies so they can bill Medicare for those braces, even though they're not needed. Of course, with the COVID-19 going around, they're trying to sell, they've got scammers calling, claiming, you know, that they can send them these COVID-19 test kits in the mail. Another one that's just now picked back up that I'm supposed to be receiving today from the Southwest region is the genetic testing kit. That where they can, check to see if, what cancers you might be in your history and things like that. Of course, if you need one of those genetic testing kits, I tell beneficiaries, go to your doctor. Your doctor is the one that has to prescribe that, your treating physician. So there's that one going around. The COVID-19 tests, are going around. There is several different scams going around trying to get Medicare beneficiaries' numbers, just so they can bill, whoever. So please, please be vigilant. I tell beneficiaries, if you get these unsolicited phone calls, just hang up. You don't have to be nice. It's okay to hang up on these people. They're just trying to get your information, and please don't give out or confirm any of your information. Just hang up the phone. Of course, there was the scams going around. Oh, another scam, the Medicare card scam. They are calling beneficiaries, claiming that, claiming to be from Medicare, and that they need to verify their Medicare number so that Medicare can send them out a new plastic card. Medicare is not sending out any plastic cards to anyone. So keep that in mind. So there's that card scam going around. Anytime there is changes to Medicare, there's always usually a scam that goes along with it. Sometimes they twist it around, and they get very creative. Let's just say that. The scammers do. Here's some other scams that I've dealt with. Ambulance services. Of course, in order to be transported, it has to be an emergency. I've had in ambulance bills, charged for more miles than actually driven. I've even had them charge, non-emergency trips as emergency trips. Durable medical equipment. I mean, fraud is rampant in this. The diabetic supplies, the braces, all sorts of this. There is all sorts of fraud in this durable medical equipment company supplies. So just please be vigilant. If you all get calls from durable medical equipment company trying to push diabetic supplies or anything like that, please let me know. Home health. I've actually had to report a CNA before. She was calling to, going out to the house, calling in, because that's how they know if they were there. So they called in, but then this CNA left. She did not provide any services whatsoever. So, billing for visits not provided, billing for services to beneficiaries who do not meet the homebound criteria. So they have to beat the homebound criteria in order to get home health. And y'all know Ryan went over those homebound criteria yesterday. Hospice care, I've had beneficiaries falsely certifying a patient that they were terminally ill. I even had one where this doctor sent a hospice referral to a company that his daughter owned. So talking about kickbacks there. But yes, in order for someone to get, hospice care, they have to have, that has to be certified that they're terminally ill and things like that. Advantage plans and prescription drug marketing. I deal with this a lot. I've dealt with this a lot here lately. I've had several Advantage plans that have switched people, even though it's not open enrollment or any of the they didn't have a special enrollment period. It wasn't annual enrollment. It wasn't Medicare Advantage plan open enrollment. So I don't know how they did that, but they've done that. But and we've got those beneficiaries switched back. I tell beneficiaries, if you're getting these calls from these Advantage plans that you have had no contact with ever, please let me know so I can report them, because they're doing marketing violations. They're not supposed to cold call beneficiaries that they've had no contact with ever before. So there's a lot, and you can actually look up the Medicare marketing and communications guidelines under the cms.gov if you really want to go through those. And I highly recommend you do that before annual enrollment, because usually I do a webinar over these, usually about August or something, right before open enrollment or annual enrollment. Nursing facility, you know, upcoding, they can always try to upcode. Sometimes they make the beneficiary sicker than they actually are, things like that. Prescription drug, I tell beneficiaries, if you can, count your pills before you leave the pharmacy, because we've had pharmacy technicians pocketing pills. Make sure it's the pill that's prescribed on the bottle. I've even had pharmacists that put a placebo in there instead of the actual pill, because the doctor couldn't figure out why his blood pressure was not going down with him taking the blood pressure medication. And then the doctor did a test and found out that pill that he'd been taking was not in his system, and it's because it was a placebo. So here is my information. If you all need me for anything, please, you know, give me a call, send me an email, send me fax, mail me anything, you know. Across the state, my toll-free number is it's 1-866-836-7677, and that number rings directly into my office. So, you know, by some chance, if I'm here, I will answer, unless I'm on the phone or I'm out or something like that. If I'm out or if I don't answer, please leave me a message and I will call you back. So I am done, and I saw a bunch of questions.
Loni. Yeah, the first one I'll go ahead and somebody asked, do you have to renew your funding grant year yourself each year, or does it roll over itself automatically?
My grant is a 5-year grant. So it pretty much, I'm in the 3rd year of my 5-year grant right now.
Yeah. We at SHIP just entered into the 1st year of our 5-year grant. And then for our low income assistance grant, that will be renewed later on this fall, just to tie that in. Yeah. Does a beneficiary receive an EOB or an MSN after receiving services, like each doctor or hospital visit? If not, how do they access these?
Now, the MSN, they only receive those quarterly if they're on original Medicare. Medicare will compile a bunch of those because they keep those, so they only send those out quarterly. Now, the explanation of benefits, it depends on the Advantage plan. Some of them will send them out, you know, once a month. Some will send them out as soon as they get the claims processed. So it really depends on the Advantage plan. Now, to see those in real time, you know, if they're on original Medicare, they would have to sign up for that mymedicare.gov account. Or if they're on Advantage plan, there's some Advantage plans where you can have your own login and password for looking up your claims in that Advantage plan. So that's how you can actually see them in real time.
Is there an S&P pamphlet we can give out to clients?
Yes, all the coordinators should have a S&P brochure. There's also has a rack card, which has like SHIP on one side and S&P on the other. Those can be handed out, mailed out, whatever. So we have both.
Yeah, absolutely. And we give out those rack cards and those personal healthcare journals at every single event. So we've always got some that we can provide to everybody.
Yeah, and for some reason, if your region is out, please let me know and I can mail some to you.
Somebody stated their concern with health literacy. How will beneficiaries know the differences in service, like X-ray versus MRI versus a CAT scan performed by their providers, to be able to report fraud?
They should be asking those questions. Unless their family, or, you know, of course, if they're knocked out, then their family members need to be asking those questions. You know, most of the time the doctor will say, well, I'm, you know, ordering an X-ray or MRI or whatever. That's why it's very important for them to take notes. If it's for the beneficiary or, the beneficiary themselves.
Loni, you've answered this already, but I'll go ahead and just put it out there so you can state it plainly. Do Medicare Advantage holders receive MSNs as well?
Yes, those are called different things. They do receive a statement. It depends on what the Advantage plan may call it. Some call it explanation of benefits. Some call it benefit summary. Some call it benefit explanation. I mean, I've seen different names for them for the different Advantage plans. But they pretty much all have the same premise. What they charged, what the beneficiary charged, what's the Medicare approved amount, what Medicare paid or the Advantage plan paid, and what the beneficiary may owe. So those have pretty much the same premise, and what the service that they got, and all of those things. It should have all the same information on them. They just may be called something different.
Now, this next question, I'll read it, but I'll put the emphasis that I perceive on this. The clarity of language used in services provided is such that who can interpret as to the services received? So I think that question is that they don't use language that somebody who may not be sort of savvy to health language, that they can't quite understand what those what things are being stated as services received.
Yeah, I understand that. There should be a code number, either a number or a letter with some numbers or something like that. It's called a code. It's called a medical code. That should be on the MSN, and I can go back to the MSN and show you what the code actually looks like for some of the services. Let's see here. Bear with me a second till I can get back there. Okay. Now, as you can see, for example, the medical code, it's the last numbers on this service. This service provided is eye medical examination for diagnosis and treatment, established patient, one or more visits. So here's the medical code that goes along with that. Yeah, some of these are, out there. Sometimes I even have to look up the medical codes to see exactly, because they can only put so much in this little bitty blank. So some of these medical codes are very, very, extensive, and have greater, more specifics if you actually look up the medical code itself than what is shown on the MSNs.
Right. If a provider does not submit the claim within the year, does the patient have any financial responsibility?
If the provider does not submit the claim, if it's past a year from the service date, then no, the beneficiary does not owe it. And that's actually stated in the provider agreement also, that they have to submit the claims within a year, and if they don't, then it falls back on the provider.
If the MSN is correct or the wrong services were billed and a beneficiary reports it, about how long can you expect to take before it's resolved?
It depends on if the provider is willing to change it. Some providers are really good and say, hey, yeah, that we did that wrong, and they'll change it immediately. Sometimes it usually takes, because they have to pull the claim back, change it, resubmit the claim. So it can take a couple months. If the provider's not willing and things like that, then I have to submit it to OIG. Once I've handed off to OIG, it is out of my hands. I have no clue what happens to it after that.
Yeah. Loni, would you point or give the number to where the medical code is located on this screen that's pulled up right here?
As you can see, I don't know, can you see my mouse where I'm circling it? Right here is the code. It's 92014. So most of the time you'll see the code right after the service description.
Somebody did ask if you're showing the form examples. I would assume that this is in regards to these Medicare summary notices. I did ask and try to find out what particular forms, but did not get a response on that. So I would assume that that has already been resolved. If a person just cannot pay the co-insurance and the provider waives it, will they get in trouble?
Not necessarily. I know there's providers out there that know. I mean, they know if this beneficiary's been going to the same provider for years. It just can't become a habit. Like the provider can't advertise that they waive, deductibles and co-insurance. They can't advertise that. They can go one-on-one basis and work it out with a beneficiary or something like that. The doctor could write it off, but it can't be the norm, if that makes sense.
How do you know what medicines are covered when you're in the hospital as an inpatient or when you have outpatient surgery?
Medicines, if you're in the hospital as an inpatient, all of your medicines that are given is billed under your Part A, because they bill that in with their Part A. Now, if you're in the hospital as a under outpatient observation, your medicine is not covered by Medicare, Part B. And the hospital can bill you for that medication. The beneficiary would have to submit that. And this is where the beneficiary needs to get an itemized statement. They would have to submit that to their prescription drug plan to see if their prescription drug plan would pay for those medications. Medicare will not pay for medication if you're in the hospital under outpatient observation, and that's the by mouth medication, the medicine that you can administer yourself, all the pills and things like that. Now, if they put something in your IV, that's a totally different thing that can be actually billed under your Part B. But all the self-administered medication, and that can be even some of your diabetic medications, Medicare will deny them if they're in there as an outpatient observation.
Is there anything a patient can do if they were told by the nurse that they were being admitted as an inpatient and later found out it was for observation?
They would have to take that up with the hospital because the hospital actually has a review team that reviews all their admissions. Even if the doctor puts them in there as an inpatient, that review team can actually change it to observation. There is a set of criteria that most beneficiaries have to meet in order for them to be inpatient. It takes more than just a doctor's signature, believe it or not. I said they have to go through the review teams. They would have to, talk to their doctor to see if he can talk to the review team, or talk to the review team to see if they can get it changed.
So somebody asked, if the COVID-19 screener asks for your Medicare number, is it a scam?
Yes.
Yeah. Boom. Easy answer.
Unless you're going to, now, if you're going to, the drive-in clinics where they're doing them at the health department or, something like that, if you're going to your doctor's office to get it, yeah, they will have to have your Medicare number so they can bill Medicare for it.
But if somebody randomly is calling you saying,
someone randomly calls you, yes, it is a scam.
Yeah. Is it true that you must be careful not to use the word yes, or they will dub it into something else and make it sound like you have agreed to something?
Yes.
See, you fell right into that trap, Loni. Now I've got you. Do we know why there is such a hard push for Medicare Advantage in recent years? It seems like every insurance agent hardly cares about PDPs and is very focused on Advantage plans. Anything fishy there?
No, there's nothing fishy. And it's because the agents do push the Advantage plans because they work on commission. They get a certain number, they get a certain amount if they sell to a Medicare beneficiary, and they get more for selling an Advantage plan than they do for selling a prescription drug plan or a supplement. So they get more for selling to a new beneficiary a Medicare Advantage plan. And if you can hold on, I'm gonna stop showing my screen. I might be able to bring that up if you'll just hang on just a second, because that just actually got emailed to me the other day.
Yeah, that's what I was looking for too, Loni.
Oh, you were looking for it? Okay.
Yeah.
The compensation for next year for the Advantage plans. Oh, bear with me if I can find it. If you can find it before me, go ahead and put it up. I sent it out to all the program coordinators the other day. Oh, goodness.
There you go, Loni. I found it.
Okay, great.
Yep, I'll pull it up for you.
Okay.
You can just tell me scroll up or scroll down.
Okay. Just okay, keep going down. Just go to the yeah, there you go. Keep going. There we go. Okay, now you can see.
Right here.
For a agent to sell someone a MA plan, if it's their first year, they get $539. Subsequent years, if the beneficiary keeps that Advantage plan, they get $270, and this is per beneficiary. Now, for selling for a PDP initial year, they only get $81. Renewals of the PDPs is only $41. So as you can see, this is why the agents really push the Medicare Advantage plans. It's because it is like quadruple, or I don't know, it could be more than quadruple, more to sell them an Advantage plan than it is to sell them a prescription drug plan. It's more money in their pocket. Now, I'm not saying Advantage is all bad. There are some really good agents out there. But you do have to, I tell beneficiaries, before you ever sign up for an Advantage plan, do your homework. And do your homework means, check with all your providers and every provider that you may ever use to make sure that they take that certain Advantage plan. Don't depend on what that agent tells you, because agents do not tell the truth. That's why they need to do their homework first. Make sure you do your research. Check with all your providers. Make sure that they're telling you all the benefits that you might be getting. Do your research before you ever sign up.
Yeah, and just to piggyback off of what Loni was saying, the reason why it may seem like that there's more of that focus on Medicare Advantage plans, at least from where we're coming from, is that if somebody calls me and says, hey, I'm on an Advantage plan, that I found out that my doctors aren't in network, unless they have the ability to go see other doctors, then the only thing that we can really tell them is that they have to not go get that care, or they have to drop that plan and pay full out-of-pocket costs. If a mistake like that is made and somebody buys a prescription drug plan that their pharmacy doesn't take, chances are they're able to switch pharmacies a little easier. It's just if someone, by their words, is duped or tricked or misled into taking a plan that is not in fact beneficial for them, it's a lot harder to make those changes and keep people being able to get their care under a Medicare Advantage plan than it is for a prescription drug plan. Like Loni said, you know, Medicare Advantage is just as good of an option as original Medicare with a Medigap or anything. It depends on what that particular person, what works best for that particular person.
Exactly.
Yeah.
Yeah. We have to tailor it to that beneficiary.
Right, exactly. Loni, we had a couple of questions come in regards to the topic that we're on. Does that commission come out of premiums?
That commission is actually paid from the Advantage plans to the agent, because a lot of agents contract with these plans, or they're only contract to sell certain plans. So they're actually the agents, because a lot of the Advantage plans don't employ agents. They contract with the agents. So it's part of their contract that's what the compensation that they will get. Now, I don't know where the Advantage plans get their money. Medicare pays, you know, Advantage plans for those. If that makes sense. So I don't know if they come from the premiums.
Yeah, it comes from whichever particular company. You know, whether it comes from the money they make from co-pays or the money that they make from, you know, from compensation from anything. I wouldn't have any insight on that either. I don't work for one of those insurance companies, but they get that money from one of their funding sources, that being premium, co-pays, anything like that. Okay. This may be a question that we really can't answer here, but somebody asked, are the agents taught to be more invested in selling the plan than making sure patients have access to what they need? It is with all knowledge in the world that I have from talking to anybody who may be involved in an insurance agency, that everyone is taught, you know, about what their plan covers, what their plans are able to offer, and there is no official training on how to you know, mislead anyone or anything like that. I think that we get on a real slippery slope when we question whether people are not taught to be invested in selling plans based off of their merit rather than any sort of misleading thing.
Yeah, agents actually have to go through training, and part of their training is ethics and the marketing guidelines. So, because that's actually part of their test in order for them to get their insurance license.
A couple of people had questions if we could make that memo available to everyone.
I sent it out to all the program coordinators, so you will have to ask because I don't have everybody's email. So you'd have to ask your program coordinators and your volunteer coordinators for that. They can email it out to you.
If Medicare finds out an agent is lying or misleading, does Medicare drop them?
As I said, Medicare does not employ agents. It's the Advantage plan companies that well, then they don't even employ them. I mean, they can terminate their contract, but if it's an agent here in the state that has a state of Tennessee license, I report them one to CMS, so that the Advantage plan can hand it on that direction. And I also report them to the Tennessee Department of Commerce and Insurance because they're the ones that hold their Tennessee state insurance license. So, and they're the ones that can investigate that, and they can actually pull their insurance. The Department of Commerce and Insurance can actually pull their insurance license or fine them or whatever they want to, do whatever with them. But I do report them into two totally. So I report them to the CMS, the regional office in Atlanta, and I also report them to the Tennessee Department of Commerce and Insurance.
Yeah.
For example, and I'm just going to tell this example that just recently happened. During this COVID-19 lockdown that we were in, we had two insurance agents that actually went into an assisted living facility while there's this was a, do not enter kind of thing, do not come in here. No visitors, while there was a no visitors restriction because of COVID-19. I had two insurance agents that went into an assisted living facility and signed up a beneficiary to a plan, even though this beneficiary told them no, and that you needed to talk to my service coordinator. But they still signed her up for a plan. And I just got an email from the investigator with Tennessee Department of Commerce and Insurance the other day that he's investigating it.
Does patient mining count as Medicare fraud, such as a house call provider coming to a patient's apartment without having an appointment?
Probably, yes. That definitely sounds kind of fishy. Yeah, most of everybody that have to have an appointment to go to people's houses, unless they've signed some kind of contract at the doctor's office stating otherwise.
How far can you go back? Years, months?
To report fraud? Yeah, I can go back years.
I would assume.
Yes, I can go back years. But I would have to definitely have the who, what, when, where, and why. I mean, I have to have all those boxes checked. And for example, I can't report a insurance agent if you just tell me he's Mr. Smith. Do you know how many Mr. Smiths are selling insurance in this state? I have to have a full, correct name. And let me tell you, we've had some go-arounds where they're not using their correct first name, they're using their middle name. Their insurance license is by their first legal name. And we actually had to find a insurance agent's name on Facebook to get his real name. So I can look up to see if he actually had a license in the state of Tennessee. So that's
and is there any penalty for any unethical behavior for healthcare providers?
Complaints, every complaint that we submit to CMS goes against the Advantage plan or the provider. So everything I submit, it gets looked at. Sometimes it takes years, especially if it's a provider that is doing fraud. Sometimes it takes OIG years to compile a case because it couldn't be just one case. It could be multiple beneficiaries over years of, however long the doctor may have been practicing or whatever. So this one may be, like a drop in the ocean kind of thing. But, it is that one drop.
Somebody put, even if there are codes provided on the MSNs and question asked during visits, who with medical knowledge reviews and confirms these services to protect the patient?
I said that's why, beneficiaries need to take notes. I know, I highly encourage, beneficiaries to share it with their family members if they've got a trusted family member to look over things. They can bring it to us. We can look over it. That's why we've got the SHIP and SMP out there, the volunteers out there, so that we can look over this stuff and see it. Hey, something doesn't look right. Anything and everything. That's why we need to train as many volunteers as we can.
Yeah. Yeah, and luckily we live in a day and age where it can be easy. You don't even have to accompany your loved ones. Every single one of my grandparents or great-grandparents puts me on the phone each doctor visit and has the doctor explain everything to myself along with them, so we make sure that we both are understanding exactly what the doctor is saying and asking of them and what charges they can expect in the future. And that may not be the correct thing. It may be a little bit overbearing, or some people may not want to do that, but there are ways that you can make sure and be that person to try and protect the patient. But to my knowledge, like Loni said, there's no like general person who's like, okay, did you understand everything in there?
There's some some providers that are really good. They'll sit down and explain on their terms, on the beneficiary's, education level, explain things. There's some doctors, you can't understand at all. So it's just hit and miss.
Is there a way for beneficiaries not on LIS or extra help to change their prescription drug plan if the premium doubles mid-year? This person said this one went from $112 to $236 effective July the 1st.
The premium changed or the copay changed?
The question says premium doubled.
Okay. I'm not sure about the premium because I thought Medicare usually sets those premiums. So
They do.
Yeah, Medicare sets the premiums, or the prescription drug plans have to submit those premiums to Medicare. Medicare has to approve those. This could have been something that Medicare did approve. They probably need to call 1-800-Medicare to see if it's something that Medicare did approve. Sometimes they tell the ships if there's changes like this. I don't know if you're aware of any changes like that.
I'm not. I would guess that it is a misunderstanding of what the premiums are. They publish all those premiums into the Medicare and U handbook, and they have to keep those premiums. And I've not heard of any CMS notice that, especially not a big premium increase like that. That would be something that would be.
CMS would have to approve something like that.
Yeah. And there are no drug plans currently with that high of a premium. So let's see here. Somebody did make sure and write in that there were some restrictions for homebound status lifted due to COVID, and that is true. And there are a number of things like that. There's a lot of things that have been lifted
due to COVID. So.
Yeah, absolutely. Loni, that is all the questions that have come in right now. Thank you very much. I appreciate you.
Thank you all. If you all have anything, please don't hesitate to give me a call, email me. I get calls and emails from volunteers, program coordinators all the time. So please don't hesitate to call me.
Yeah. Even if you suspect something to be fraud or abuse, it's better to let Loni know about it, because she can give you a much better idea of whether it is or is not. All right, we're coming up on about noon or 1 o'clock Eastern time. Why don't we go ahead and take a break for right now? Why don't we say that We'll meet right back here at 12:45 Central Time, 1:45 Eastern Time to give everybody an hour for lunch here. I'm good? Perfect. All right. Yes. Yes, we can.
All right. Well, there it went. It went away. I'm one of those that, like a lot of the others, has not ever done this before. There we go. Is that good for everybody?
Yes.
I am Ivy McDaniel. I am the program coordinator for the Northwest region, and I'm here to talk to you today about the low-income subsidies to help people with their Medicare prescription drug plans, and any other cost savings we can get them on Medicare. Some of the ways they can get help with Medicare is for the Medicare premium is for the Medicare savings program. And that is from the Medicaid or TennCare. It helps pay the Medicare costs, including the Medicare premium. QMB would be the only one that would help pay on deductibles or coinsurance. So we're going to talk about that. We're going to talk about the low-income subsidies. That's extra help on the prescription drug plans, and that could help pay on the premium for those drug plans and also help pay on the drugs, their costs themselves. Medicaid is a federal state health insurance program for people with limited income and resources. The only thing I do with Medicaid is help people with the Medicare savings program. And I'll talk about that a little bit more later. So Medicare is a national program, and it's consistent across the country, all across the United States. It's administered by the federal government, and it's insurance, health insurance for people 65 years of age or older. Now, certain people that are under that age group that have been deemed disabled by Social Security could get on Medicare on their 25th month of disability. National primary payer of inpatient hospital services to the disabled, elderly, and people with long-term care services with end-stage renal disease or ALS or Lou Gehrig's disease. Medicaid, on the other hand, is a statewide program, and it varies among the different states. We have a lot of people that move into Tennessee from other states going, well, my Medicaid in the other state paid a lot more than this one, but I'm sorry, you're in Tennessee now, so that's the way that happens. It's administered by the state governments with federal rules, the federal and state partnerships to get that taken care of. It's health insurance for people based on need, financial and non-financial requirements. It's the nation's primary public payer of acute health care, mental health care, and long-term care services. To qualify for the low-income subsidy for the prescription drug plans, if you have full Medicaid, you automatically qualify for help on your prescriptions. If you get SSI, which is a program that helps people that have a very low income, if you receive SSI, you automatically qualify to get extra help on your prescription plan. And if you have a Medicare savings program, such as QMB, SLMB, or QI1, you automatically qualify to get help for your prescription drug plan. All others must apply. I do most of the applications that I do are online with Social Security at www.socialsecurity.gov. You can call the toll-free number there listed at Social Security. We have 3 Social Security offices in our district, and I call those locally to talk to the Social Security about getting an application done or the status of an application that's been done. And you can also contact your SHIP office, which is all of us. So some of the income and resource limits in 2020 for this low-income subsidy is an income below 150% of the federal poverty level. That would be $1,595 per month for an individual, or $2,155 per month for a married couple. And if you have dependents in the home, that amount would be higher. So it would all depend on how many people are in the home and how many dependents you would have. I don't have the number for like an extra dependent or anything right in front of me. So resources, that's like your checking account, any bank account, money you have put back. I ask people a lot, do you have money put back in your mattress, in your pillow, or in a hole in the backyard or anything? This is properties that you have. If you have own a lake home or a residence, and you have 2 different homes, then that's going to count as part of your resources. And so they're going to count your resources. So an individual with resources of up to $14,610 could be eligible for this low-income subsidy. A married couple with resources up to $29,160 could be eligible for this low-income subsidy. And this includes the $1,500 per person for funeral or burial expenses. It's already included in that. And so you got to count all your savings accounts and your CDs and investments and all of that, but it does not count the home that you live in, reside in, or the property that it sits on. It can help reduce your premium by $32.74. That's 2020's national premium rate across the nation. It could reduce the co-payments for your medications as low as $8.95 for brand name medications, or $3.60 for generic medications. It could reduce your drug plan to 0 deductible. And you are exempt from the coverage gap or donut hole. And you could also, if you're very close to that income limit or that resource limit, you might get 25%, not 100%, or 50% or 75% help on the cost of your medications and your premiums. You can do an application for Social Security help on low-income subsidy, either through a paper application that comes from Social Security. If Social Security believes that you are have a low enough income, if they see that in your file in their system, they might mail you out an application. You can call Social Security and get one. You can go online and get one and do it automatically online and turn it in online. Or you can contact the State Health Insurance Assistance Program, and we will be glad to assist anybody with that. Now we're going to talk about, where'd it go? Medicare savings programs, the income and resource limits for that. QI1 has a monthly income limit of $1,456 and a resource limit of $9,360. That's for an individual. For married couples, the income limit is $1,960 and the resource limit is $14,800. And QI1 only pays your Part B premiums. And a lot of times, if you get something in the mail from TennCare stating that you qualify, it may say you qualify for SLMB and not the QI1, because QI1 is a lot of times lumped into the SLMB. So And then here's the income limits again for the low income subsidy. That's $1,615 for a single person with resources of $14,800 and $2,175 for a married couple with resources of $29,160. And we just spoke about what it would pay. So I'm going to jump right on to the next one. I skipped one somewhere. Bear with me, folks. I apologize. This is what I needed right here. I couldn't find. So the other part of the Medicare Savings Program is the Qualified Medicare Beneficiary, better known as QMB or QMB. An individual has a monthly income of $1,083 or less, has resource limits of $9,360. A married couple has an income limit of $1,457 and resource limits of $14,800. And this QMB or QMB helps pay for Medicare premiums, Part A and or B. Not everybody has Part A premiums. If you've paid into the system, you heard earlier in the presentations in the last 2 days, that if you've paid into the system, you will not have a Part A premium. Some people never paid into the system, so they do. And if you get QMB, it will help pay the Part A premium. It also helps pay deductibles, co-insurances, and co-payments. So if you get QMB, you get everything. It pays the premiums, pays the deductibles, co-pays, and everything. But the SLMB, SLMB, the income limit on that for an individual is $1,296 and resource limits of $9,360 for the single person. And for the married couple, it is $1,744 and with resource limits of $14,800. And the SLMB, like the QI1, only pays the Part B premiums. So just remember that QI1 and SLMB both pay the Part B premium, and the QMB pays Part A and B premiums and helps with copays and deductibles, anything Medicare leaves behind. And another thing about the QMB, as long as you're on that, you cannot be billed. So that would be a good thing. I threw this in here. A lot of people don't talk about this much, but this is something I think is pretty relevant to what we do and what we need to tell our people that are maybe transitioning off of Medicaid and going on to Medicare and have a lapse in coverage on their drug plan. Medicare has a limited income newly eligible transition program. If a person has got extra help or has Medicaid and for whatever reason found themselves without a drug plan and has one starting the following month, you can use this LINET program that CMS has put together through the Humana to help people get that prescription at the lower cost. Most pharmacies can find that. A lot of pharmacies are not familiar with it as I'm using terminology today, but it's always available for those people that do have the low income, that find themselves without a prescription drug plan for whatever reason, and that have a drug plan coming up in the future. This only works for a couple of months at the most, I would think. You call the pharmacy up. I've done this many a times with a lot of different people. Call the pharmacy, give them this BIN number, BIN number, 015599, and this PCN number, 05440000, And they should be able to pull that person's medication up and tell them what that lowest cost is for them. I've used this a lot, and I'm glad I found it when I started this program early, so I would know all about it. You can also go to this website here and get a brochure on it and hand that out to the pharmacies around and let them know that this is available for people that do have a low-income subsidy or that are getting off Medicare and will still have the low-income subsidy and that does not have a prescription drug plan for whatever reason at the moment. And this can help them get through that. Helpful websites, the TennShip website, Medicare.gov, Medicaid, TennCare. This is what I keep on my desktop all the time for the Medicaid or Medicare Savings Plans applications. Social Security and healthcare.gov. I'm going to click on the TennCare application if we can't go there real quick. And this is, as you can see, a 16-page application. The front page tells you everything you need to know about filling out this application. I used to fill these out all the time. I now do most things over the telephone. You can apply for Medicaid with this. You can apply for the Medicare Savings Programs with this. Include everybody in your family. It tells you what all you need to get this application completed. And it'll ask you about their income and any other information that needs. And you will send this application if you're going to mail it to this address here. You can also fax it, which is what I used to do, to this number here. And I would suggest that if you fax it, to make sure to get a receipt that that fax went through and how many pages went through and to what number it went to. You can go online to www.10careconnect.tn.gov, fill out an application there. You will have to create an account to do that. I've done that maybe twice. I don't do that very often because most people I deal with do not have email addresses and do not want an account in the TennCare system. If you need help completing this application, there is a phone number here you can call and they will be glad to help you with it. If you're in our local area, any of us coordinators will be able to help you with that. I'm speaking for everybody. I hope I'm true and correct on that. So here's more information with getting help completing this application. I don't usually fill this part out too much anymore. I used to put TennShip in there, but I would not fill this out at all unless they had a family member that they wanted to represent them or be able to access their information, then I would fill that out. And this would give you permission to do whatever at the bottom here. Whoever's name is in here, you would mark what you would want them to do on your behalf. And it would also ask how long you'd want that person to be helping you. If it's an organization, you can put TennShip. You can put the signature here. If you've got an ID number, I guess we could put our SHIP numbers in there if we have them, and the date we did the application. Then it's going to ask us about who is needing this application completed. Enter their name, first, last, and middle name, their address, their city. Make sure to get an apartment if they're in one, the county, state, and zip code. And if their address is different than their residence, to receive their mail, you'd want to make sure to get their mailing address in there, their city, state, zip code, county. Put a phone number in there. That would be pretty necessary. We need all of this filled out to make sure that the state has everything they need to make this happen. And who you include on this application: yourself, your spouse, your children or stepchildren under 21 who live with you, anyone you include on your tax return, even if they don't live with you. So anybody that's on your tax return, you would want to make sure to have all their information because it's going to ask for it. You don't have to include your parents who live with you, but file their own tax return, or other adult relatives who file their own tax return. So I say if you've got dependents and you're filing this out for you, filling this out for you, then you need to put their information on here. So everybody, we just answered that first question about who is filling this application out. That's the same information that's going to go right here. Same person, same date of birth, their sex, their relationship, their social security number. So are you applying for health coverage with us? If you're applying for Medicaid, yes, you're applying for health coverage. If you're applying for the Medicare Savings Program, no. And then your ethnicity, race. Have you ever been known by another name? I would put my maiden name in here if I'd been ever known by another name. So if you're approved by TennCare Medicare, there are 3 health plans to choose from. So they want you to choose Amerigroup, Blue Care, or United Healthcare. So if you're applying for TennCare Medicaid, you will want to check these boxes. And I've had people say, well, how do I know which one to choose? I have no idea what to tell them. Have you heard of any of these? Do you know what works in our area? Have you talked to your doctors about it? You would need to know who you want to choose right there. And most people don't know. So we just choose one. I'll say, which one would you want me to mark? And they will tell me. You need to tell them whether you're a Tennessee resident or are you temporarily living out of state. And if you are temporarily living out of state, do you plan to return to Tennessee? And when you plan to return. If you are younger than 22 years old, what is your school enrollment status? You can skip this question if you are 22 or older. Are you a U.S. citizen or national? Are you a naturalized derived citizen? I am a U.S. citizen. So I skip that number 16 and 17 and 18 and 19 and 20 and 21 if I answered yes to number 15. If I answered no, then all of these other questions are going to have to be filled out, 17 through 21. Question 22, are you eligible to get services from an Indian health service, a tribal health program, urban Indian health program, or through referral of one of these? I'm not, and I don't know of anybody in my area that is. I have not run across anybody in my area that is, and I've been doing this a while. So continue with person 1. That's the person that's applying for this help. Wants to know if you will file taxes next year. And if you do, then write down the name of the spouse or any dependents you'll claim. And are you being claimed as a dependent? Wants to know if you're a primary caregiver to a child under the age of 19 and who they are and what your relationship is to them. Are you pregnant or were you pregnant in the last 60 days? And when is your due date? Are you enrolled or entitled to enroll in Medicare Part A and B? Now, if you're applying for the Medicare savings plans, you want to make sure to say yes on that application. Have you experienced an emergency health problem and need help paying for those emergency services? Yes, sometimes. No, most of the time. For instance, on that is a man took a air evac to another hospital over 100 miles away. And that air evac asked if you want us to file Medicaid for you. And that flight cost, I think it was $50,000. I don't remember now exactly what it was. But you could put yes in that instance. Have you experienced emergency health problem, need help paying for those services? So that flight was $50,000. Yes, I need help paying for that. I have experienced that. So it depends on if they've experienced it or not. Are you 26 and were in foster care at the age of 18 or older and lived in Tennessee at the time? So you'd want to answer that question. Are you under the age of 65 and getting treatment for breast or cervical cancer? You want to make sure to answer that question. Are you in the hospital and have been there for 30 days? Or are you in the hospital and will be there for at least 30 days? And if yes, when did you go in? And tell us the name of the hospital and the doctor's name and the phone number. Do you live in a nursing home? This might apply to a lot of nursing home people. Do you need hospice care? That's yes or no. Hospice care is for people that it used to be for people with end-of-life situations, but they've extended that to deal with other people who are just bedridden or unable to take care of themselves. So those are questions that will have to be answered, and we'll need to know the answers to. Are you over the age of 65? Are you an adult with physical disabilities and want to receive home and community-based services? Most of these questions here do not fall under my realm. They fall under the Choices program. So if this question is something that you want to receive home and community-based services, you click yes. But for most of the things that I do this application with, I click no on a lot of these questions. But they use the same application for the Choices programs as they do the Medicare savings programs and the long-term care services. But we have to go through each and every one of them. Do you have intellectual or developmental disabilities and want care at an intermediate care facility? So you'd have to answer that question. Do you have intellectual or other developmental disabilities and want the Choices program? You need to answer that. Do you have Medicare and want to keep getting Medicare cost sharing like QMB or SLMB? Definite yes on that. Anytime I fill out this application. Number 36 and number 26 are my two main questions I'm looking for that I want to count yes. I'm trying to get these people help paying their Medicare premiums. This is mostly what I do and what I'm trying to get for these people. I just have to go through all the questions. Number 37, did you receive supplemental security income or SSI benefits in the past but don't now? Answer that question. Do you have expenses for things that help you work because you're blind or disabled? Answer that question. We're still talking about person one on this page 6. So are they employed, not employed, self-employed? Most of mine are not employed. And you skipped question 49. Wants to know about other income you get. A lot of people get pensions. So we want to make sure we let them know that there's a pension and how much it is and how often they get it. Social Security benefits is on there. So you want to make sure how much that is and how often they get it. So there's a lot of other types of benefits on here. Veterans benefits apply a lot of times. Retirement accounts apply a lot of times. So just pay attention to what it is and make sure that you get all the correct answers on there. So if you're self-employed, answer questions A and through C. Does anyone have other than a parent or spouse that helps pay for food or housing each month? Sometimes people do have other people that help them with their food or rent. I don't run across people that help with that too much. Some people get help with food stamps. Some people get help through programs in the community that help pay the rent. You just need to know all those answers and make sure this is all completed. Do you have medical or dental bills for care you've received in the past 90 days? Answer that question. Do you have shelter, utility, dependent care, or child care expenses? Yes or no? Most people say yes because you've got shelter and utility. And then you would answer before tax deductions. If they're on Social Security, no, they don't have any before tax deductions that I've been run across. I've not run across that at all. Excuse me. Do you have expenses that can be deducted on a tax income, tax return? Educator, business, deductible part-time and self-employment, health savings account. Remember, that's been brought up before during this training. If you had a health savings account and you paid into it while you were getting onto Medicare, you may have a problem and may have to get that information right there. So all of that counts. Make sure to fill this thing out completely. And I would not put lines or anything through it. I used to, but I don't do that anymore. If it don't apply, I used to put NA. I just skip over it and don't put anything in there. Now, if you have another person living with you, we're going to start the whole process over, and you're going to have to fill out everything about that person in this part of the application. And I'm going to skip over it because we went through all of those questions on person number 1. So person number 2 has to answer all of those questions again. If you have more than one person living with you, you may have to duplicate the application and put more like person 3 and fill this all out for them. So in step 3, they want to know about your health coverage now. Is anyone on your application enrolled in health coverage now? Answer that question. Answer the name of the health coverage, what type of health coverage this is, who's on the policy number, group number, date started, and is it an employee benefit? This application here, this part of this application is not talking about Medicare. It's talking about some type of employment coverage, marketplace coverage, something of that type. This is not talking about Medicare. Does anyone have access to health coverage but is not enrolled? That's access to employer coverage, marketplace coverage, anything that they could be enrolled in that they're not enrolled in. It is not talking about Medicare at this point. So this is talking about the family resources. They're going to ask, do you have cash, checking account, health reimbursement account, IRA accounts, loans, stocks, bonds, retirement, promissory notes, patient. Just go through each and every one of these and make sure that they answer to you if this applies to them. And then you're going to have to describe all of the information about whatever it is. Say, I've got a retirement account. I'm going to have to write it in there, the value of it, everybody that's on that, and tell them where it's bank, all about the information, where it's located, address. All of that information is going to have to be on there. Does anyone own any property? Yes. I own my own home. But I do not own rental property, life estate, a duplex, apartment building. I do own my own house or condo. Wish I did have a condo. Vacation home, mobile home, land, or farm. You will have to answer this. If it's yes here, you have got to mark something in here. And then it's going to want to know more about that information that you just told us about. Life insurance. This is one of the things that we always get caught with, life insurance policies. If you have a life insurance policy and you're trying to fill out this application, you'll have to mark yes. And then who owns the policy? Is it a term or whole life? What's the face value of this policy? What's the cash surrender value of this policy? What's the policy number, the name of the company, address, city, state, telephone number, all of that. A lot of people don't think they know that information, and they won't supply it. So you just have to do the best you can. And if TennCare comes back and they say, we need this information because you marked yes, it's going to have to come up. Either you've got this policy or you don't. And if you have it, we've got to have that information. Going to ask about burial. Burial resources, contracts, or lots. It's going to ask all the information about all of that. It's going to want to know if you own a vehicle. And is it a car, truck, motorcycle, trailer? All of these things. So you'll have to know what you need to put in there. It's going to ask who owns the vehicle, what year it was made, what's the make and model of it. Is there anything owed on that vehicle, and how much the vehicle is worth? If you don't know how much a vehicle is worth, I go to Kelley Blue Book all the time and hunt up make, model, year of a vehicle, and you can find out an estimate of what it's worth with how many miles are on it. Do they get income from this vehicle? In my area, that would probably be no. In the larger cities, it could be yes. But most people that I would deal with use that vehicle for household transportation. Is there any other type of resources? Yes or no? How much is it worth? What is the resource? How much is owed on each resource? Have you given away, traded, or sold anything in the last 5 years? Be very careful there, because people could have transferred properties from one household member to another household member or to a stranger, who knows. But make sure whatever they tell you, you put down. And if it's not right, it will be caught. So then it tells you more about this application and what you need to tell, how to fill it out. Let them read that page there. If I'm filling this out by paper, I usually hand them that page and let them read it. Want to know if you're registered to vote where you live now. Let them tell you whether they are or not. Would you like us to mail a voter registration application? You need to let them know that. And if they do income tax, they have the right to get this renewed automatically for the next 5, 4, 3, 2, 1 years. Or if they don't want to have the information from the taxes returns renewed, then they don't have to. That's their choice, so they get to choose. Then they need to sign it, for sure there, and date it. If I was mailing this application, I would make sure to get a copy of this application to keep for the record for that person, and give them an envelope and put this address on it, and give them a stamp and an envelope and send it out to them. That's the way I do it. That don't mean that's the way you have to do it, but that's the way I do it. You can also fax it. There's the fax number one more time to that. Make sure to get a receipt that that fax went through to that address, that many pages. I always put a cover sheet on it. I usually have my name on that cover sheet with the date that I sent it. And that is how to fill out that application for Medicaid or long-term care services or the Medicare savings programs, which is what I use the application for. Is there any other questions right now? Brian?
Yes, Ivy, there is. I'm sorry, I was on mute again.
That's fine.
I had a question. What did you say QI1 stands for?
I don't know.
Qualifying Individual 1.
Okay. There
Why is there a 1 on the end of it? You got me. Nobody asked us when they named it.
Right. Now, I don't deal with QI1 very much at all. It always rolls over into SLMB. So.
Yeah, the main difference with QI1 is that that program is funded with a certain amount of money each year, which renews on an annual basis. So once that money is used up, so essentially there's a number of spaces that are available for QI1. Once those spaces are filled up, nobody else can qualify for that. At this point in the year, being halfway through the year, I'd say your chances of qualifying for QI1 are fairly low.
But Ryan, let me ask you this. If they qualify for QI1, would they not automatically get rolled over? I've run across several that did qualify for QI1 and they got rolled over into SLMB. And I think for the reason of the money.
I'm not saying that it can't happen, but they are of no obligation to have to do that.
Okay.
You know, by the letter of the law with TennCare.
Okay.
Somebody asked, what is the difference between monthly income and resource limit?
The monthly income is like your Social Security that comes in. It's money that's coming into you. Your resource limit is the amount of properties or money you have stored back in the bank or properties that you own. Does that help out that question?
Yes. I think that was very good. How do they, meaning TennCare or the Social Security Administration, how do they confirm your resources that you've reported on your application?
Well, I know that I can go online and hunt up people's properties anytime, any day, anywhere. So it's all a matter of the government databases having that information and them looking into it to see what they find.
Okay. Can we get this PowerPoint, which includes the LINET info? It wasn't in the one sent earlier. Somebody sent that question in. It was sent on the one on Monday, but I do know that a couple of people that I sent that email to reported to me that they were having trouble receiving emails with attachments. I will resend the emails that I sent out on Monday for people that may not have received it because their inbox did not allow files sent that large. I will break those up into 3 emails and send those specific for day 1, day 2, day 3 to everyone that I have on the email list when I was sending out those invitations. If you're not on that list and you still want those, so essentially if you do not receive 3 emails from me today, please go to your SHIP coordinators in your region to get that information.
Thank you, Ryan.
Yeah, you're very welcome, of course. The next question is there help with completing the application available in multiple languages? Someone did comment right below that and say that it is available in Spanish online, but they can call the number for an interpreter.
Correct.
Would you repeat where you go to find out the value of a vehicle, please? My PC broke up when you said that.
Kelly Blue Book.
Yeah.
I'll try to pull it up real quick.
Yeah. Here, let me give you presenter again, Ivy. Hang on.
Oh, I'm not there yet. I guess I have to go back there. Am I there?
You might want to share your screen again. I had taken the ball back. Yeah.
I'm working on it. If it'll pull it up. Am I there?
You're on you're on the screen, but you're sharing there it is. Yep.
Okay. So I go to my car's value. My computer's a little slow right now. But Kelly Blue Book is where you go to. And you can search your car's value. I'm waiting on this to pull up. And you could put in the year of the car, the make of the car. There you go. So we'll just put in boy, my computer got slow real quick. I think it's because of Kelly Blue Book. They got a lot of extras on there. So we'll just say a 20, did it pull it up? 18?
Yeah, 2018.
Acura. ILX, whatever that is. And put my zip code in here. And then however many miles is on it, we'll just say 200,000 miles on it.
Boy, you have really driven your car a lot in 2 years, Ivy.
Well, I'm going to tell you what, my car gets nearly 100 miles a day on it if I drive to Martin.
Yeah.
So I put miles on my car and then all the other driving that I do. So we'll just say it's a 4-door sedan. You'll have to ask the person that owns this car. I don't know. We'll go next. Select your options. We'll just say price with standard equipment. That's what I normally do. I got the mileage at 35,000 there. So. And you have to tell them what color it is. We'll just say it's gray. And we'll just say it's in good shape. And then we'll click next when it allows me to. I think it's thinking, but I'm not sure. And then it'll tell you. Well, it's usually right here. Okay. Trade-in value, $13,098. Right there. Y'all see that?
I
Brian,
certainly do. Yeah, I certainly see it.
So that is the Kelly Blue Book is where I go to find that. Always use standard options unless they tell me, oh, this car's really got a lot of stuff on it, you know. So that's how I get the value of a vehicle.
Yeah, that's what I use in all situations too, Kelly Blue Book. Somebody asked you to please go over again the difference between what is shown on slides 3 and 4 regarding 2020 Medicare savings programs.
Okay.
But I pulled up that presentation and it looks like that's in regards to extra help on slides 3 and 4.
On the Medicare savings programs. Qualifying for extra help LISPDP plans?
That's the presentation that you were giving. I just opened it up from what you had sent me, and it looked like it was extra help. You could confirm if that was what slides 3 and 4 were in your presentation, though.
Low income subsidy for extra help. Yes, and the income and resource limit. Yes.
Yeah. Yeah, so if you would just go over that. That is not, and whoever did ask that question, that is not, in fact, a Medicare savings program. That is the entirely separate financial assistance program that helps with your prescription drugs.
Correct, yes. The LIS is the low income subsidy, and that goes through Social Security to get help for prescription costs and prescription premium costs. They have to be below 150% of the federal poverty level. An individual can make $1,595 per month. That's their gross amount before any deductions. A married couple has to make below $2,155 per month, and that's the gross amount before any deductions. And their resources is $14,610 for an individual, or up to $29,160 for a married couple.
Yeah, and that includes a $1,500 per person burial expense right there too. And I did have it come in. I did have it come in the chat box too to remind everybody that that $144.60 that most people are paying for their Part B premium that comes out of their check automatically before it gets deposited into the bank, they do count that $144.60 towards your gross income.
Part of your income.
Yes.
Absolutely.
Yeah, absolutely. I'm going to stop sharing this real quickly so I can pull up these questions again. Do vehicles that are not working and have been parked for years have to be counted?
Any vehicle on your property should be counted if it's got a license on it or registered.
Yeah, with the exclusion of your first of one vehicle per adult family member.
Yes.
I think if you can get money from it, then you have to count it.
Yes. Even if it's not working, that is a countable vehicle.
It's part of your resources.
Yes.
Now I'm not going.
Yeah, and Ivy, that is all the questions that had come through. There are a couple of things that I do want to make sure and mention to everybody too, that when you're dealing with these TennCare applications, you do have to be very careful. Somebody just asked, what is the one vehicle per family member exclusion refer to? That is that they do not count your primary vehicle. So if, say, I was a married couple, then they would not count up to 2 vehicles when looking at my resources. But if I, say, had 3 or 4 vehicles because my hobby was working on, classic cars, they're going to count my 2 primary vehicles, and they're also going to count the 2 vehicles that I work on in my spare time as well. Or for example, go ahead, Ivy.
Or if I've got a vehicle, my husband has a vehicle, and we have a pickup that we use to haul things around with every so often. Or if we have a motorcycle that we like to ride around on, they're going to count those extra vehicles.
Yeah. RVs, campers, boats, all that good stuff. I do also want to make sure everybody knows that you do have to be careful when you're filling out that application. If somebody were to mark that person was interested in choices when they were not, and they were only interested in a Medicare savings program, TennCare will slow down that application process to make sure that they get everything they need for that choices determination. And that is a little bit more intensive than a Medicare savings program determination is. So please do be careful if you're not.
I'm sorry. I will also say that I have lately been calling TennCare to do these applications over the phone. And I will let TennCare know that I am on the phone and that they will be speaking to the beneficiary, because I will not do that application for the beneficiary. However, if the beneficiary answers anything that I think he needs to look at again, I will jump in on the conversation and say, are you sure you want to answer that question that way? Because this is what's going to happen if you do.
Yeah. We've had a couple of questions come in while we've been talking here, and I will go over the vehicle thing. Seems to be throwing a lot of people here. For every adult family member Yes, for every adult family member. So if you've got an adult child living there too, you can count one vehicle towards that person, and it is excluded from your resources. Any vehicle, motorcycle, boat, RV, camper, or anything like that, scooter, if it's past your first primary vehicle, it counts for one vehicle per adult in your household.
Every vehicle counts.
Yep, that's right.
On the paper.
Right. Lawnmowers do not count. So if that's how you drive to work, just count yourself lucky. I don't judge. I will also say that I know that, no, hang on, I want to make sure. Yep, I'm not.
They're jumping on everything.
No, the vehicle of the value of the vehicle does not matter. The vehicle does. It does not count only if it's in the applicant's name. If all three vehicles, if I'm in a family of 4 and all 3 vehicles are in my name, then one of those vehicles will be excluded for myself. One of those vehicles will be excluded for my wife. Now,
but know that all of those vehicles have to be on that application.
Yes, 100%. If you exclude a vehicle and TennCare finds out, then they would have the ability to cut off your assistance immediately. That is lying on your application. Now, I would make sure that you're very clear on that application too, which of those vehicles is primary for yourself or your spouse or any adult child in your household, because if you were to not list which one is your primary vehicle and put your most expensive one as not your primary vehicle, then TennCare probably will look at the value of that vehicle and it may not go to your benefit. I cannot guarantee that. We do not make determinations on those applications, no matter how many people out there will tell you that we're the ones who handle that. The only thing we do is write down the information on the application for people and send it in.
Right. And the value of the vehicle does matter.
Yes, and you do have to list every vehicle on that application, but they will exclude one vehicle when they're looking at what your total resource is. I also will say that when sending in this application, I know that a lot of people do not have access to the internet, and that is not easy because you have to do that online. And you have to have an email address. We do not encourage everybody to take that on yourself because, for example, if I set up an email address for somebody, I have to trust that they're going to be able to log into that email address because that's where all those updates will come, is to that new email address. So if they're not able to check that, you know, we are not caseworkers. I do not expect anyone to sit and check our beneficiaries' emails every day. However, if you've got that option to do that online, that is by far the most optimal way of putting in this application. If you fax it in, if you mail it in, TennCare has 45 business days to render a decision on that application, and they usually do take those full 45 days. I sat in on a TennCare meeting once they announced that they were doing this online, and they told me that their wait time for paper applications is typically up at that 45 business day limit. Their wait time for approval on those online applications is typically much lower. They said it could be fast as 24 to 48 hours. So
I've been told 2 weeks.
Yeah, in any situation, it seems to be that online application will be the fastest way of doing that.
Or telephone.
Again, or telephone. But I would just make sure that, you know, if given the opportunity, you shoot for that. The same thing with the extra help application as well. I don't know that we got the opportunity to show that, but I will just show everybody really quickly here.
Oh yeah, I didn't think about that. I don't do the paper applications on the Social Security low-income subsidy, but I do those online.
Yeah, absolutely.
And
a lot of what Ivy went over is on this extra help application. This is the easy application right here.
Absolutely.
I think everybody can see this screen right here, so I'll just scroll down, and Ivy, if you want to add anything to this, then you can feel free to jump in and interrupt me at any point.
Yeah, if you've got anybody that qualifies for this low-income subsidy, absolutely get this application in, and then at least that will get in and get in process quicker than that MSP application would. So
and I do get questions too. Is submitting an MSP application or submitting an extra help application, is that sufficient for applying for both? On paper, yes, but you should be completing both of these applications. If you're doing a LIS application, you should also be doing an MSP application, because I have heard it from people that those applications do not always get to TennCare or do not always get to Social Security in the appropriate amount of time needed. So if you're submitting an application for one of them, especially if you're doing an MSP application, make sure you go to Social Security's website and fill this out. If you Google SSA Extra Help or SSA, Social Security Administration.
.gov.
Yeah.
Will you go to will you go to that website while you got that
yes,
up?
I absolutely will. I just want to, because we won't be able to go and look through all these questions on the website, but I'll do that afterwards. Now it'll ask, are you assisting someone else with this application? You can fill that out if you want to. I typically do not, because I've never had anyone contact me about someone's case. So after about 5 or 6 years of taking that time, I've stopped doing that.
Now, on the website, I do say that I am assisting and give my name, and then it wants to know your relationship, and that would be other, and you would put TennShip in there and the toll-free number.
Sure. It asks for the applicant's first name, last name, Social Security number, date of birth, and this is as it appears in Social Security system. I will give the example. My grandfather's date of birth has been incorrect in Social Security for as long as he can remember. It's his date of birth is 8/24. They've got his date of birth as 8/25, and try as I may, I've not been able to get that switched for him. He won't let me go down there with him and give me that authorization, and he won't go do it. So we just know now that if we do anything, I know to put the incorrect date of birth on. What's in Social Security's record. If you're married and living with a spouse, same information. It will ask you if you've got resources higher than the limit. If you put no or not sure on the website, it'll just say you don't qualify. Or excuse me, if you say yes, you do have that, it'll say no, you don't qualify. If you say no, it'll push you forward. Ask for the combined total of all bank accounts, all stocks and bonds, any other cash at home or anywhere else. That's cash that's buried in the yard under a mattress. If you do have that cash and you put it on here, hey, you are honest. If somebody did have cash buried in the backyard and they told Social Security, yeah, I've got millions buried in the backyard. I don't know why they do that, but that's up to somebody's honesty right there.
Right.
It asks the question of, will any of this money be used to pay for your funeral or burial expenses? Again, they disregard up to $1,500 towards your funeral or burial expenses. Other than the home and the property on which it's located, do you or your spouse own any other real estate? That's anything not standing on your, if your private home is, 500 square foot and it's on 100,000 acres, that still is considered your primary residence. But if you've got a 500-acre house on 1 acre, but you own 100 acres somewhere else, that will not count as your primary home.
I will also interject on here that I've run across people with the house on the property and the property next to it being part of their property, but on a different deed. That is 2 properties. If you've got more than one deed on 100 acres, then you've got 2 properties.
That's right. How many relatives live with you at this time? They define that by blood, adoption, or marriage, but not including your spouse. You can answer that. Where does your income come from? Social Security benefits, railroad retirement, veterans benefits, other pensions or annuities. Do you have other income not listed above, including alimony or any of these other things? I will submit this, I will email this PDF out later to everybody so everybody can take a closer look and examine that too. Has anything from this question decreased within the last 2 years? If you've worked in the last 2 years, what do you expect to earn this calendar year? If not, then you can skip these. From self-employment, what do you expect to earn? Has that decreased within the last 2 years? If you stopped working, when are you going to stop working, or when did you stop working?
And a lot of people have stopped working.
Yeah.
In the process of getting this application filled.
Do you or your spouse have to pay for things that enable you to work? You know, wheelchairs, treatment for drugs for AIDS, cancer, work-assisted technology, things like that. It asks you, do you want us to send this information to TennCare to file for a Medicare savings program? I have never said no to that, even if somebody was over the limit for a Medicare savings program.
Yeah, me either.
But I do not rely on that to be the only application that I do for a Medicare savings program.
Absolutely, correct.
Yeah. And then they ask for information, signatures and everything like that are not on the online application. It asks you to agree to, you know, I agree that all of this information is correct and that I've answered honestly, things like that, but they would need to put their mailing address, sign that. You know, if you've assisted, you would need to sign that and specify. It's the same information that if you say yes online that Ivy told you we have to fill out. You know, we would put other and put ship right there. But I will go ahead and pull up the, let me just pull up Google here, and I'll go through there. That way everybody can see how easy it can be to access that. And I'll show. Yep. But we'll go ahead and show everybody from Google.
Is everybody enjoying these presentations we've been doing like this instead of in person? I like the in person, but I like this also. I'm kind of a hermit anyway.
Definitely can dress more comfortable, even though I'm in office 100% now. So if you were to go and just put, well, here we'll just do extra help. Then the first thing that comes up right here after the ads, you can ignore anything with an ad next to it, is ssa.gov, like Ivy was saying. That's Social Security Administration.gov, and it says extra help with Medicare prescription drug plan costs. And you can pull that up right there. I'll show you from, if you just go to straight ssa.gov, how you can access this as well. But if you pull that up from Google, that always seems to be somebody can manage to figure out Google fairly easily. You would just click apply, and it starts you in that application. How can you get this? What is this application? What do you want to do? Apply now. If somebody has to leave an application for any reason, once you've entered in all their information, it will give you a sheet that says here's their access code, and you can return to that application at any time. But if you click apply now, a few times. Yeah, amen. Especially for if somebody can't quite remember their information or if it doesn't match up. Whoops, let me see if I can go back one. No, okay. It just basically that last page was an agreement that I'm going to provide honest information on this application. I'm not going to try to be dishonest with Social Security in any way. I do have a couple of people that say, well, I can't quite remember, you know, the specifics of this. I always tell people, answer it honestly to the best of your ability. If you're a couple $100 over on your resources or something like that, if you say, I've got $1,600 in the bank, but you actually have $2,000, Social Security's not going to be, they're not going to throw up red flags over that. But if you say, I've got $1,600 and you've got $16,000, I don't think anybody could defend you trying to be honest at that point.
Right. Would you mark
right.
yes right there on that question?
Yes, I will.
Okay.
Did you receive an application in the mail from us? Most people know, they're just looking for help. Do you or your spouse have Medicare? Yes. Are you 64 years and 9 months old or older? You can answer that as, you know, depending on what that person's age is. Have you received Social Security disability benefits for 24 months? Again, yes or no, depending on what their answer is. In which state do you live? What is your marital status? And do you have less than what resources you need to qualify for this program? If you say yes, it takes you forward and says, here's what this information, whoops, let me go back. I must have clicked something. No, I do not have combined savings investments. Yeah. See, that last page said, okay, you don't qualify then since you've got that much money. But if I say, no, I don't have that much money, it takes you that and it allows you to apply. You put in that person's information. Again, like Ivy said, if you want to put that you're helping this person complete this form, you can do that. And put that information in there. Again, you would put relationship, other, and then put ship in here. You can put your phone number on there. You can put our ship hotline if you so choose. I would not put that ship hotline. I would not put my personal number. I would put a business number in there. I would put my office number, yeah.
And a business address.
Yeah. And then it asks everybody's information, and if their information doesn't match up, it will tell you you get 3 tries to put in the correct information. So, and then it locks you out for, I believe, 24 hours. So if you don't get it right and it locks you out, you need to encourage the person to go to Social Security or call them, make sure what their correct information is before you move forward on that. And let me stop sharing really quickly here and see if we've got any other questions that have come in. If you complete both applications, when the LIS applications makes its way to the TennCare office, would it knock the previously submitted MSP out of the process, or would they recognize it's a duplicate application? No, if you send in a duplicate application, TennCare will ignore the second one. How does a person apply for SSI? You would have to contact Social Security to apply for SSI. If you call the Social Security toll-free number, you can register to get an appointment instead of hanging on. They will tell you the appointment time date pretty accurately. Yes. How is the President's stimulus unemployment supplement going to affect SLMB recipients? It is my understanding that they are not going to take those payments into account when it comes to SLMB, and that they will not be canceling anyone's Medicare savings programs based off of that increase, that one-time increase that people have received thus far. I'm not going to sit here and say that we haven't heard of people getting taken off because of this, because it's not a regularly earned income. It's a one-time payment received. You know, I myself have experienced some people saying that they've lost that even though they're not supposed to, but it should not be affected.
Because it's not really income.
Right, exactly. It's a one-time payment.
Due to a
due to a pandemic.
pandemic. Yeah, that's what I was looking for.
Okay. Well, thank you, Ivy. I'm going to pause the recording, Zoom recording. Okay, there we go. Now we're recording again. With the Plan Finder, we go through Medicare's website. So what we're going to do is go up into the search bar here and go to Medicare.gov. You can see it's one of my saved URLs because it gets used pretty much on a daily basis. Sorry, everybody. I wanted to make sure that drop-down screen stopped. Now, when you go to Medicare.gov, this is the home page here. You know, I usually like to say, yeah, you'll see this picture, that picture. They change their picture on their home screen fairly often. It shows these two people right here. It may show a grandmother and her granddaughter. It may show a person sitting in a chair sipping out of an indiscriminate mug. It all just depends. Social Security changes the layout of everything pretty often, but what we're going to be focusing on for Plan Finder is right down here. It's going to be Find Plans, Find 2020 Health and Drug Plans. Now, why would we use this website and what is it for? We use the Plan Finder to do comparisons on people's prescription drug plans or Medicare Advantage plans. You can also look at Medigap policies on Medicare.gov. However, you know, I typically do not. I use our comparison tool for Medigaps that we looked at yesterday if I'm going to look at those Medigap policies because I'm able to find out a lot more information through that CSG tool. But let's say that we receive a worksheet or a call from somebody who is looking to get assistance with picking up a prescription drug plan or a Medicare Advantage plan. So what we would do is go to Medicare.gov and look right down below where this picture is and look for Find 2020 Health and Drug Plans. Again, it used to be over here. It used to be over here. It may change places, but you want to find health and drug plans right here. And then this is what comes up, find a Medicare plan. And then I do not want to take a survey. What we want to do, if that person has created an account on Medicare.gov, we would like for them to provide us with their login information first and foremost. When someone creates an account on Medicare.gov, Medicare will put all of their information on their Medicare account. Any of their Medicare summary notices should show up here. It should have a list of all services that they've incurred within the last year should show up on here, so it can be pretty helpful to have all that information. It also will add any prescription that they've filled and that they've had charged to their prescription drug plan will show up as on their drug list right there. However, I do not have anybody's login information right now. So what I'm going to do is go right under here and go continue without logging in. You can absolutely do that if somebody does not have an account or does not want to create an account. You can absolutely continue without logging in. We want to log in with an account or help them create an account if possible. However, we do have people that are fairly against that. Creating an account does not shut off them receiving their paper notices. However, if they do wish to only receive electronic notices, if they select an account, they can have all of those notices sent to them through their email. So what I will do is I will hit continue without logging in, and it's going to ask us to answer a few quick questions since we're going off somebody that they do not have a profile for. Now, it's going to ask us, what type of 2020 Medicare coverage do you want? Now, right here, we're going to say that we're going to do a comparison of both prescription drug plan and Medicare Part D plans individually. We're not going to look at Medigap policies. We're going to say this is a state employee who's thinking about going with POMCO, but wants to look at standalone drug plans and wants to look at a Medicare Advantage plan just to check and make sure whether they would prefer to go with a Medicare Advantage plan as opposed to going with a Medigap policy here. So I can select, one or the other. We will have the opportunity later on to look at the other option. But what I'm going to do right now is I'm just going to select Part D drug plans because it'll be easier for us to compare drug plans first and then compare Advantage plans, because a lot of doing that will take out half of the explanation of looking at Advantage plans by doing drug plans first. So what I'm going to do is I'm just going to select a drug plan right here and then enter your zip code. Again, I do not have, a particular zip code, so I'm just going to use my future zip code here. And I will be living in Davidson County, so I'm going to use that. It does give you the option to select county. You do need to make sure what their zip code is and what county they're located in. And then, do you get any help or cost with one of these programs? Do they receive Medicaid? Do they receive SSI? Do they receive an MSP or extra help? It does give you the option to say, I'm not sure. With I'm not sure, it will not include any assistance, or you can say, I don't get any help from these programs. Typically, people do know, well, I get help with my drugs, or I'll say something like, do you get Medicaid or SSI? And they typically respond, with a pretty definitive response to that. Or I'll say, does the state pay for your Medicare Part B premium to cover a Medicare savings program? Something to try and get that information of do you receive assistance in any way possible? If they don't know or they're not sure, you can mark I'm not sure, or you can just say, I don't get any help from these programs. We're under no obligation to be held to have to be 100% right with doing these comparisons. If they do not identify to us and we cannot identify for them whether they're receiving any of those programs and we mark I don't get any help, it will overestimate what their costs will be, but that is on the beneficiary, not on us to know that knowledge. So once I select that, we'll hit next, and it asks, do you want to see drug costs when you compare plans? Now, for somebody who does not take any medications, then you would just mark no. But for somebody who does need medications, you can mark yes right there. We're gonna put drugs in right here. How do you normally fill your medications? Do you use a retail pharmacy? Do you use mail order? Do you use both? If someone is interested in mail order pharmacy, I always just go ahead and put both. If they're not interested in mail order pharmacy, then I'll just click retail. So I'm just gonna do both. I'll do both right here. And then once we select that, it asks us to add our prescription drugs. Since I do not have a drug list in front of me, I'm just going to add a few random drugs. We're going to say that this person takes a insulin right here. We're going to say that they take Lantus, yes. So you'll see that when you enter in, a drug, it gives you a bunch of options here. You find the drug that you need and hit that, add drug. If I enter in a drug that somebody wrote down and it doesn't come up, I'll usually just open up another tab and Google that name that they provided to see if possibly they spelled it wrong, or if it's the name for, if it's an older medication that has since been replaced with a newer medication that, say that there was a medication that replaced this medication, I will put that in place for that medication and let the person know on that comparison this was not included on Medicare's website, so I used this newer form of that same medication in place for that. Please do check with your doctor whether you're actually receiving this medication or if it's actually, you know, another medication that you just know it as this older name. But right now we've entered Lantus and selected that, so I'll hit Add Drug. Now it gives us options of dosage and package, since this right now is set as a pen injector. If I was to go ahead and change the dosage, so what I would do if I'm looking at different dosages, and we'll do this again for other medications, is if that person gets a solution in a bottle, then it changes that. Instead of packages anymore, it comes in as vials. So what you have to do is, if somebody says, I take 30 units of insulin each day, then what you would need to do at that point is, we know that there's 100 units in a vial. You can see from right here, there's 100 units per milliliter in this solution. So in a 10 milliliter vial, in a 10 milliliter vial, so 100 units per milliliter in a 10 milliliter vial, that means there's 1,000 units in that vial. So they take 30 units a day. That means that vial will last them for 33 days right there. So when we're doing this, we would say, okay, well, if they take 30 units a day, how many vials do they need to get them through 30 days every month? If they want to change that frequency, they most certainly can do that. You know, they can most certainly, that was strange. Yeah. If you want to look at the package and see if they sell those in a package of vials, you can check that there. But we're going to go ahead and just say that this person gets their insulin on a monthly basis. So every month, not every 2 or 3 months. And since we just determined that they'll have enough units in a 10 milliliter vial to sustain them for 33 days, they'll only need one of these vials per month. And we'll add that. Now we're going to say that this person takes, or what I should have done is go back to drug list. When you enter that, all of that information will show right here. Name of the medication, package type, quantity of how many packages of that you're getting, and then the frequency every month. You can remove that. If you accidentally put the wrong thing, you can edit that right here. But once you make sure that all of that's correct, you have a choice. Is that the only drug they take, or do they take more drugs? Well, this person takes 3 medications, so we're going to go and hit add another drug. They take Xanax, not Xanaz, Xanax. And you see, once you enter that, you can click that, it's the only Xanax, so we hit add drug. Now, it asks us, it lets us know a generic for Xanax is available. Xanax is a lower cost generic version called alprazolam. Would you like to add alprazolam to your list instead? On our comparison sheet that we use, our PDP worksheet that we send out every year around open enrollment, and I send out to almost everybody who wants a comparison of any drugs or any Advantage plans, it asks on there, do you take the brand name of any of these medications, or do you take the generic of these medications? So people usually are aware whether they take that or not. If they'll know whether they take, you know, Xanax or whether they take alprazolam. If they're not sure, you can have them check that bottle right there and ask them, does it say Xanax or does it say alprazolam, and get them to check whether they take the generic or not. Now, I did this to emphasize that it does let you know if a generic is available. So what I'm going to do is I'm not going to say add the brand instead. I am going to add the generic of this. So at this point, it asks us, what dosage do you want? And you have to ask that person, do you take a 1 milligram per milliliter concentrate? Do you take a 0.25 milligram tablet, a 0.5 milligram tablet, 1 2 milligram tablet, a disintegrating tablet, a tablet with extended release for 24 hours, and what is the dosage on that. You have to find out what their dosage is. So we're just going to say instead of a 0.5 milligram, they take a 1 milligram tablet for alprazolam. And we're going to say this person takes 3 a day, which would be 90 every month, but this person picks up that medication every 3 months. Frequency is every 3 months. So they take 3 of those alprazolam tablets a day, so 30 days in a month, and they pick that up every 90 days or every 3 months. Excuse me, every 90 days or every 3 months. So what we're going to do is times that by 3, and we'll see that they're going to need, Sheila chimed in and said you can't pick up Xanax every three months. This is just an example right here. You cannot actually pick up alprazolam every 90 days. I'm just using this as an example. It's a poor example to use. But we're going to set the quantity for 270 every 3 months. Now, that's 2 of their medications added right here. What we're going to do is add 1 more medication, and we're going to say that they're going to take lisinopril. L-I-S-I-N-O-P-R-I-L, lisinopril. Right there, add drug. Nothing changed for this. Lisinopril is a low-cost medication here. What is your dosage? We're going to just leave it as a 20 milligram tablet. This person takes 1 a day, picks it up once a month. So we're just going to leave that quantity at 30, and we're just going to move forward. And since we've added all 3 of their medications, we're going to go ahead and click Done Adding Drugs. Now, because we included mail order in this, it's going to make mail order one of our pharmacies selected. It will allow you to select up to 3 pharmacies. Mail order, if you select that, takes up one of those spots. So what we're going to do is we're going to go ahead and select one of the big box pharmacies, Walgreens right here. In general, those big box pharmacies, pricing's not going to differ crazily through those big box pharmacies in general. But so if somebody says, well, you know, it depends. If I can get a better deal at Kroger versus CVS versus Walgreens, anything like that, you can add all of those and check between those. I'm going to go ahead and just put Walgreens in there, and I'm going to try and see if I can find a not big name pharmacy here that's we can add that may be a little bit different. We're going to go ahead and put Green Hills Pharmacy. So once I've added 3 pharmacies right here, including mail order being one of those, then I would hit Done. And because of all of the barking that we do in our program, those will automatically now come up as being sort plans by lowest drug plus premium cost. What that means is with your premiums and copays included, it's going to be listed from the least expensive down to the most expensive of these plans right here for this particular made up person that cannot actually get this medication on the same, cannot actually pick the same medication up on the regularity that we have put in here. So you can see that based off of this imaginary person that I just created here, that it will give you the answer of how much you'll pay yearly plus premium costs with all of that at a retail pharmacy, at mail order, what their deductible will be. And you can see as we scroll down here that you'll see the pricing go up with each one that we go down. Now, typically what we do with the program is we select the top 3 of these medications, of these plans. So what I'm going to do is click Add to Compare, scroll down to the next one, Add to Compare, and Add to Compare. And then I'm going to click Compare. Now what that's going to do, and I just selected, you know, with no, I didn't tell y'all what the name of the company was, anything like that. I just went from here's what the biggest cost savings would be, and here's the next two down. So the three that came up as being the most cost effective for this imaginary person that I made up right here are Cigna Health Springs RX Secure Extra, Envision RX Plus, and AARP Medicare RX Saver Plus. If we look on here, it tells you what your monthly premium is, tells you what your yearly drug deductible is. Again, premium is sort of what most people would view as like a membership fee. It's what you have to pay each month to be a part of that plan. Your deductible is what you must pay out of pocket before your plan will start paying for your medications. In general, plans with deductibles are most cost effective over the year as opposed to a plan without a deductible. If somebody wants a zero deductible plan, we can absolutely do that. I'll show when we go back to that last page that we were on how to do that. But just know, in general, plans with deductibles are more cost effective over the year for the majority of people. You can also see right here, it'll show that same information right down here. It will have a check mark if that plan is accepted at these particular pharmacies. I still do have people call their pharmacy and just double check. I like to be doubly thorough and not to just trust the information right here. I think that people doing just a little extra work is not too much to ask, but if it shows up on here, then I find it to be 99.9% of the time it's the truth. But it will give you an estimated total drug and premium cost, and will tell you what their annual cost will be at each one of these things. At the Green Hill Pharmacy, it's going to be $470.80. On Cigna, at the Green Hill Pharmacy, on Envision, it's going to be $719.62. And on AARP Medicare RX Saver Plus, it's going to be $808.20. It does look like that overall, Walgreens is going to be more cost effective than these other two choices is for Cigna. If they were to want to go with Envision, then mail order would be the cheapest out of those three options. And if they were going to go with AARP Medicare RX Saver Plus, Walgreens would be cheaper as well. But if y'all, all of you listening right now, were my beneficiary, the way that I would explain this would be as follows. These are the three plans that cover your needs the best and are going to cost you the least overall for the year. It looks like that under this plan, you'd be paying $54.60 a month, and you would have a $100 deductible. Under Envision, you'd be paying $14.20 a month, but you would have a $435 deductible. Under AARP, you would be paying $28.90 a month on your premium. You would have a $435 annual drug deductible, but it does look like that overall, Cigna Health Springs RX Secure Extra would be the most cost effective for you, somewhere in the $350 to $400 range, depending on what pharmacy you did choose, followed by this Envision RX. That would be somewhere between it would be somewhere between $650 and $820. And then if you went with AARP, it would be somewhere between $750 to about $810 would be that. That would be the evaluation that I would give somebody. Now what we can do is go in and look at those plan details on each one of these as well. And I do print out this page plus a copy of each one of these plans detailed pages when I'm doing the comparison. Now, when we go to the plan details page, it shows the same information that we've looked at before, you know, what your premium is, what your deductible is going to be. You can also look, you know, at star ratings. All of these things will be on here as we go down. Well, computer froze up here. There we go. Nope, computer's going wild on me. If we scroll down, we can look at drug costs and coverage. and then we can see what the tiers are for each one of these medications as well. You can see that preferred generic, generic, preferred brand, non-preferred brand, specialty tier, and select care drugs are all the tiers here. And you will also be able to look at what these selected drugs are going to cost you. Hang on one second. Just want to make sure that I didn't leave anything out, and if my computer wouldn't be lagging. There we go. That's the information that I was looking for, is it will show you what tier your medications are in, and whether you have quantity limits. Now, as was shared earlier, you must have less than 4, you must take less than 4 per day in 30 days. You cannot pick up 90-day supplies for that alprazolam. You can only pick it up once every 30 days and no more than 120 tablets during that time period. All the other ones do not seem to have any other prior authorization or quantity limit needs. However, Lantus is a very expensive medication. You can see Tier 1 would be your cheapest medication, followed by Tier 2, all the way down to Tier 6 being your most expensive medication. And that deductible will not apply depending on what tier your medications are in as well. If you're only having to pay for Tier 1 medications, then you probably will not meet your deductible, or that deductible would not apply to you in that scenario. Now, if we keep on scrolling down past these cost and coverage, it's going to break it down from between pharmacies right here. So we'll look at Green Hills, which again is not what the most cost-effective pharmacy is for this person, but we're still going to look at it here. You'll see what the retail costs for those medications are, what their cost will be before the deductible, what their costs will be after the deductible, and what their cost in the coverage gap is going to be once they reach that. Now it looks like that in estimated drug costs, this is not going to include right here the plan premium of $54.60. However, right here, it does include that. So if you were to calculate all this up right here, that's not going to be including what your premium is on this right here. You'll see that you will not meet your $100 deductible this year, and you can see how much your estimated monthly drug costs are going to be under this plan, $28 in July. And this is only going to show you what it's going to be for the remainder of the year. It will not go from January, since we are, in fact, halfway through the year at this point. And you'll see that, you know, while that drug retails for this much, the actual cost of your medications are going to be much lower. So, for example, you're going to pay $28.10 in July. In August, you'll only pay $6 because these are the only 2 medications that I've got filling every 30 days. September, you pay $6. October, you'd pay $28.10. Then in November and December, again, you'd pay $6. That is not including the $54.60 that you will pay for your premium, but this will be how much you would pay at the pharmacy to pick up your medications. Under Walgreens, you'll see a similar scenario to what's going on right now. You're going to be paying $367.16 for the remainder of the year with your copays and premiums included. To pick up your medications in the pharmacy, you'd pay $12.16. Again, that is because this is set for every 90 days. That's why you see it skipping 2 months between these costs, because these 2 are the only 2 that are set for 30 days. So in July, I'd be paying $12.16. In August, $3.81. In September, $3.81. October, $12.16. November, $3.81. December, $3.81 to pick up my medications at the pharmacy. The same thing with mail order. It's laid out the exact same way. Mail order is shipped to you every 90 days, so it cuts out the months in which those are, since 90 days is the only option in terms of mail order pharmacy, it cuts out the months in which that is not being sent to you. So July and October would be the only 2 months, and you can see that what those medications will cost right there versus what that's going to cost you, since lisinopril has no cost and $24. Then in October, you would have to be paying. Let's see. I don't see how that would be 28 right there, but I'd have to look into that. And then the same information, it shows you your tiers, it shows you know, your selected drug list. And again, if you wanted to edit or remove any drugs, you can do so right here. And then it gives you a star rating. We talked about those star ratings a little bit earlier. You can take a look right there and see, you know, for drug plan customer service, if my computer, you can see what those star ratings are based off of that. Again, you know, you want to give that information out to people if they're asking for it, but if a plan is not low rated, you do not have to, you know, you do not have to make sure you go over that. You can look at an overall star rating and see that information right there, and let them know all of that. But the particulars of why it's rated that many stars, I typically only go over if somebody asks me about that. And then contact information. If a person wants to call and ask that plan any particular questions, which I always think is a good idea if the person's done enough and has enough time ahead of them where they can take the time to call that plan and ask them any particular information that they're interested in, I always think that's a great idea. But that information's right there, and it will let you know what the member and non-member numbers are. Obviously, if somebody's not enrolled in that plan, they need to call the non-member number. If they are in that plan, then they can call the member number. And it also gives the plan's website right there. And I typically do print each one of these out and highlight all the pertinent information on there, you know, the premiums, the deductibles, what their costs would be, you know, in each pharmacy, you know, all of this information right here. And then go back to comparison. This is going to be the side-by-side, all three of them lined up there. That we can see this, and then I would open up the plan details on each one of these and print those off, and all of that information looks similar right there when comparing, you know, prescription drug plans right there. And we can look like through all of these and help a person determine themselves what plan they'd like to go with. But I always do let them know, hey, this is going to be the lowest cost policy for you based off of this. These are estimates, but they are typically within about $1 to $3 of where people report to us that they actually end up being. So they are fairly accurate and pretty dependable to rely on. If somebody were to, for example, say, you know, I'm interested in a, you know, blank, blank, or blank plan, then we absolutely can say, like, okay, well, you told me you were interested in a Humana plan, so I'm just going to scroll down, find a Humana plan, and add to compare. Or if they said, I'm interested in Farm Bureau, or I'm interested in SilverScript or anything, you can absolutely scroll down and add whatever somebody wants. But typically, if they're not looking for a particular plan or not looking, you know, for a plan, they can absolutely, you know, pick whichever one they want. But in situations where they're not looking for something in particular, I always just default to the 3 most cost-effective plans. And I do, you know, always make sure that I show somebody the comparison of the most cost-effective versus what they're asking me for. However, I have signed people up for plans that are 10 times more than what they should pay, and I've signed people up for plans that I thought were the most cost-effective. It is not up to me to decide what somebody wants. It's only up to me to provide them with the information to let them know what is the most cost-effective. If somebody tells me I don't care, that's the plan that I want, then that is the plan that they will absolutely get because that is their choice. Now, we've compared prescription drug plans, and I told y'all we would have the ability to compare Medicare Advantage plans later. Well, if you look on this screen, you can see this ribbon right here. There may be Medicare Advantage plans available with lower drug costs. Tell me more. If you go just to the right of that, you can see view 33 available Medicare Advantage plans. And what it'll do now is switch these. Loading. To Medicare Advantage plans. And it will have everything laid out, except now it's got health benefits included in here too. So what I'm going to do is the exact same thing as what we did before. I'm going to scroll down and add to compare the top 3 of those plans and have them laid out in a little bit easier, digestible way for us to look at here. And all 3 of these lined up from left to right here: Cigna Health Springs True Choice, Bright Advantage Choice, and then Bright Advantage Flex Choice. You'll see what the premium is for all of these. Like has been mentioned earlier today, a lot of those Advantage plans will have a $0 premium and may not have a health or drug plan deductible under those. They do have out-of-network limits to those plans that offer out-of-network. You'll see this Bright Advantage Choice HMO does not offer out-of-network right here, but these other 2 PPOs right here do offer out-of-network coverage. Obviously, if you stay in network, that is going to be much lower, $5,900 on this one, $5,900 on this one over here, and then $5,700 in the Bright Choice that only has in-network allowed. But you'll see if you go out of network on these PPOs, that maximum out-of-pocket jumps up to a $10,000 limit right there. With the premium, they have added on here, you'll see $0 health and drug premiums right here, but they do make sure and remind people that your Part B premium you're still responsible for that if you take a Medicare Advantage plan. That does not go away if you opt out of original Medicare. You stay paying your Part B premium even if you are taking a Medicare Advantage plan right here. None of these plans have a health deductible right here, and like we went over, their maximum out-of-pockets are listed right here. $5,900 in network, $10,000 in and out of network, $57,000 in network, $59,000 in network, $10,000 in and out of network. You can see Cigna, Bright Advantage again. That's it, Bright Advantage Choice. This is Bright Advantage Flex Choice. What we have right here is all the additional benefits that these plans offer, and you'll see which one of these offer any particular additional benefit. You'll see that this plan offers things like dental, vision, and hearing, but doesn't offer transportation, while this one does. This one does not. They all offer some fitness benefits. They don't offer any over-the-counter drug benefits or in-home support or home and bathroom safety devices. This plan may offer meals for a short duration, where these 2 will not. This one does not pay for annual physical exams, where these 2 do. And then this one will help pay for some telehealth, some endodontics, periodontics, extractions, where these two will not. I'm sure that in terms of telehealth, these plans probably are making exceptions at this point in the year due to the pandemic that's been going on, but typically they would not. And then it shows us benefits and costs through that health, those health benefits. You'll see for a primary doctor visit on this Cigna Health Spring plan, to see a primary doctor in network will cost you $5 of a copay per visit. If you go out of network, that's a $40 copay per visit. To see a specialist will be $30 copay per visit. Or if you go out of network, that's a $55 copay per visit. For this Bright Advantage Flex right here, you have to stay in network, so it's a $0 copay for as long as you see a doctor in network. If you go see a specialist, it's a $30 copay. For this other Bright Choice plan, if you go in network, $0 copay. If you go out of network, you pay a 35% co-insurance. So you can sort of look at copays as being dollar amounts, co-insurance as being a percentage right there. If you go see a specialist, as long as you stay in network, you're paying $35 copay to see your specialist. Again, if you go out of network, you're paying a 35% co-insurance right there. There are things like tests, labs, and imaging that you can look at. Doctor and hospital are typically the things that the majority of people ask about, so I'm going to focus on those. As was discussed this morning, these plans do differ, you know, in terms of how much they're paying for hospital stays and differ on how many days they'll pay for. It looks like that all of these pay days 1 through 5, but they could say days 1 through 4, days 1 through 7. It all just depends on the plan. For this particular plan, if you go in network, it's going to pay. You're going to be responsible for paying $310 per day for days 1 through 5. So you'll be paying $1,550 if you've spent 5 days in the hospital. $0 for days 6 through 90. If you go out of network, you're paying 40% per stay. Outpatient hospital coverage, you're paying anywhere from $0 to $250 per visit. What differentiates a $0 visit to a $250 visit? The best answer I can give is it's probably due to what all specific services you're needing. If you're needing something that's a little bit more, for lack of a better term, invasive, then perhaps it would be closer to the $250 copay. But if you went in to, you know, get a routine check or something, you may pay nothing for that. However, if you go out of network, it's a 40% co-insurance per visit. For this plan that offers no out-of-network coverage, you'll see it's $275 per day for days 1 through 5. So you're going to pay a little bit less than $1,500. You'll probably pay closer to $1,400, maybe a little bit less than $1,400. And you'll pay nothing for days 6 through 90. Outpatient hospital coverage, you'll pay $300 copay per visit. For this plan, you'll pay $275 per day for days 1 through 5. So again, you're going to pay just under $1,400 for 5 days in the hospital. You'll pay nothing days 6 through 90 though. However, if you go out of network, you're paying 35% per day for days 1 and beyond. So that can rack up rather quickly. And then outpatient hospital coverage, if you stay in network, you're paying $325 per visit. If you go out of network, you're paying a 35% co-insurance. You can look at things like preventive services, hearing aids, to see whether anything like that is covered or not covered and how well it's covered. What's your copay going to be for these particular services? Skilled nursing facilities, durable medical equipment, diabetic supplies. It also brings up your drug costing coverage right here too. And again, you'll probably see that these are lower than what those prescription drug plans are able to offer. Those drug prices are. Typically that's because Medicare Advantage plans are charging copays for their health benefits, because they do include health benefits and are able to offer their drug costs for a little bit lower because of that ability. But I'm going to show everybody the plan details just really quickly here. And you'll see that it looks much similar to the prescription drug plan page when you went and looked at those plans benefits. I'm not going to spend the same amount of time going over everything as in depth as we just did, but you'll see things like your total monthly premium. They still remind you that you're still paying your standard Part B premium. They show estimated yearly cost. That is based off of how often the average person goes to the doctor, sees a specialist, goes to the hospital. I don't put a lot of value on this portion right here, but you could use that to say an average person may spend about this much on this plan each year. But I typically deal with people who who are not quite going to the doctor nearly as much as what the average person does. So typically this is a little bit confusing for people who are looking at that and thinking, oh, geez, if that's what they're estimating that I'm going to have to pay, I don't like that plan. It's not. It's an estimated total based off of the average person, how often they go to see a doctor and go into the hospital. So your maximum out of pocket, again, it shows you, and this is the, excuse me, I'm sorry, I believe this is the Cigna. This was the plan that was on the left when we were going over all of these benefits. So you'll be able to see, you know, all the information that we did, primary doctor visit, all the diagnostic tests, urgent care. You can absolutely open up some of these categories, and it'll show you a little bit more in depth with some of these categories, extra benefits, preventive dental, comprehensive dental, any other benefits, you know, fitness benefits, some coverage. I do want to make sure that that people do notice that, you know, let me see if I can find an example of this. Some of these for benefits and everything, it will say something to the extent of coverage may vary or something like that. So that's the situation where you would definitely want to call that company or that insurance plan and make very sure of how much something is going to cost and how well they cover that particular thing. If we keep scrolling down, you'll see the same setup as when we were looking at drug plans, drug cost and coverage. Then it's formatted the same way by pharmacy, and will show you based off of you know, the rest of the month, how much are you going to be paying in each month. You know, Walgreens mail order is still set at every 90 days, so that will show up differently than the other two looked. It will have drug tier information, star ratings. You can, my computer's lagging a little bit. This plan is too new to be measured. Typically, they have to be in the market for 2 to 3 years before they can attain a star rating. So this plan must have been created within the last 2 or 3 years, and therefore does not have a star rating at this time. Just because a plan is new does not typically mean that it's bad. It's just new, and we usually give it a couple of years before we can look and see what that star rating is. And then, of course, contact information, that is all right there. And again, for somebody who is not a member of that, they'll want to use the non-members plan. Somebody who's actually in that plan can call the members line, as well as the plan website. All of the comparisons look like that. They're a little bit better laid out than they have been in the past. You know, overall, the Medicare.gov sprang this change on us and redid this right before open enrollment. So we were on the back foot, and we were trying to really catch up and really deal with all the learning curves of looking at a new system. It looks like that they've been able to resolve a lot of the issues here. There are a couple of underlying things that we still are going back and forth with them to help them resolve, but overall it's a little bit better laid out than it's been in the past. And you know, typically if you're wanting to print these, I'll show everybody. I find that Google Chrome is better at sort of printing these. I don't know if I can get print preview here. Yeah, I can. But what I typically do is when I hit print, it's automatically set to shrink to fit. I'll shrink that down to 60 or 70%, where everything fits on here a little bit better, and try to have that all fit on there better. At least it prints a little bit cleaner when I shrink that down too. So what I'm going to do is I'm going to stop sharing my screen here and try to look at these questions. I know that we're a minute or two over the time, so I want to make sure that I'm not keeping everybody on here too late, but I want to make sure that I give everybody time. Somebody asked if you do qualify for TennCare, you can still get Medicare Extra Help. In regards to the last presentation that Ivy gave, yes, if you qualify for a Medicare Savings Program through TennCare, you will automatically qualify for Extra Help. Through that, it's not the reverse case, though. If you qualify for Extra Help, you will not automatically qualify for a Medicare Savings Program. Ivy did answer that as well. Let's see here. Yes, Sheila, thank you for letting me know about the Xanax there. Isn't the estimate shown only for the balance of the year? That isn't for the period of the following month through the end of the year. Yes, it's only shown for this year, from the point that you are in the year through the remainder of the year. In the situation where the monthly drug cost doesn't equal the monthly drug cost, I experience this often. Yeah, that's been something that I think that that's just been a calculation error. There was a point when we were doing these comparisons where these prices would vary wildly depending on what your dosage was on your medication. They seem to have corrected a lot of that, but you will see every once in a while that from what those drugs are priced based off on the comparison, those numbers don't quite add up. However, for that scenario, it was only about $4 off. That one, I didn't really have a way to answer that. But for example, if you're going from one cost period, say you were going from your deductible to your initial coverage period, meaning you've paid off enough to where your plan will now start paying their 25%, you'll see a split charge on that where you pay the remainder of your deductible and then you pay up to a certain percentage of the remaining cost because you've met your deductible and you're entering into your initial enrollment period. That's a little bit real high up and really complicated. It took me about 3 days of searching and getting my head wrapped around that before I was able to really comprehend that. So I don't want anybody to get too bogged down in that that right there. Let's see here. Can you cover mail order options? From what I understand, each company has their own carrier of mail order, and you have to take those mail order options up through your particular insurance company. You can't compare different mail order companies, for example, unless you know the specific company, and even then, it's only going to give us their retail option if it's going through that right there. If seniors are tech savvy, are they able to use this website on their own? 100%. It's the best thing that anybody can ever tell you is like, oh, so I can do this myself? Yeah, I'll just handle this myself. Great, fantastic. This is not something that is solely for SHIP. Anyone in the world can go to Medicare.gov right now and can do all of this themselves. It's just that we, with SHIP, have been trained to be able to do this and can do it fairly quickly. And I would bet that any of the volunteers or any of the coordinators who have been with the program for a little while could probably do comparisons in their sleep at this point. What is the difference between standard in-network and preferred in-network? The companies do set up agreements with particular pharmacies. If a pharmacy is a preferred pharmacy for your particular plan, that just means that that company has gotten the best agreement with that pharmacy, and you most likely are going to be able to get the best deals at your preferred pharmacy because they've negotiated a little bit better pricing of their medications and how much they're able to cover medications at those particular pharmacies. Trying to get the information of what's the preferred pharmacy for each plan is something that we don't typically do. I would suggest going to that that plan's website to try and find their preferred pharmacy. Can you explain the drug tiers again? Absolutely. Let me just open this up really quickly, and I'm just gonna open this so everybody can see here. So all companies are subject to putting the drugs that they cover in any particular tiers. That is, each company is perfectly able to put whichever drugs they want in any particular tier. The tiers right here that they have, yeah, it looks like, yeah. There are 5 tiers right here, and they go from preferred generic, which you'll get the best pricing on, generic, preferred brand, non-preferred brand drug, and specialty tier. So those plans will set those particular drugs that they cover into a particular tier, and that will base at how well that company will pay for those particular medications. It's why somebody asked the question, I don't know if it was yesterday or early today, why plans can offer different prices so drastically, is that they cover particular medications in a different way. Typically, in general, again, in general, there are exceptions to all rules, but in general, the plans with the lower premiums typically don't pay as well for high costing medications, where those plans that have higher premiums will cover those high costing medications a little bit better than those low premium drug plans at that point. Let's see here. Will some Advantage plans pay the Medicare Part B premium charge? Yes, it is my understanding that some of those will pay that Part B premium. I believe that started this year. I do not know what those plans are that are currently doing that, but it is my understanding that there are at least 1 or 2 of those plans that are offering that at this point. I don't know if that is in our state, if any of those exist, or if it is just in different states. But I want to say that, and Adrian, you or Marcus, y'all can feel free to chime in and tell me if y'all have any recollection of this as well. But I seem to remember that one of y'all's volunteers said that they were aware of at least one in y'all's area that paid for that when I was there back in February, I believe. Yeah, that's just what I remembered. You know, I'll unmute the both of y'all if y'all can tell me if y'all remember that. I'll give y'all that opportunity.
I don't recall that was here. Marcus, how about you?
I believe we had one, but I'm not sure of the company.
Okay.
Yeah.
I believe
Yeah, we
I believe
researched
it's that
that one.
gentleman that was right up front.
Oh, that guy. Okay, yeah.
Yeah.
Yeah, we had. Did he say Cigna Health Spring? Did he say?
Yeah, he thought it might be a Cigna plan, so that would be something we have to look into. I do remember
Okay,
now he was speaking about Cigna.
Yeah.
Okay, perfect. Perfect.
Okay.
Thank y'all very much. Let's see here. Okay. The dollar amount that is shown on the plan details section is the amount that the policyholder pays and not what the company pays, correct? Yes, that will be the, I believe you're saying right here, what it shows, that would be Tom right there. Yes, that is, that right there, it shows what the policyholder will be responsible for paying, not what the plan pays. If you want to calculate what the plan pays, if you were doing this comparison and you look at what the retail cost is, and then you look at what the cost is after the deductible, then you could see how much the plan actually is paying for those medications. But what the policyholder is responsible for would be right here. Is there any way someone can find out ahead of time what pharmacy in their area is most preferred by customers? If not, why not? I don't know that anything out there would have, any information about what's most preferred by customers, but you can most certainly find out ahead of signing up what pharmacies your plan prefers in your area, or what plan. You can call any of the plans you're looking at and find out what their preferred pharmacies are in that area. But it will also let us know if one of your, when we do this comparison, if your pharmacy is a preferred pharmacy when we do these comparisons as well. Someone stated earlier you showed an insulin in Tier 6. Yes, that is correct. It was a Tier 6 in that particular drug plan, but since now we're in a different company's plan, and we're also in Medicare Advantage, it does not appear as a Tier 6. Under this company, they've got that in a Tier 3. So that was my point that I was making earlier, is that each company can set any particular medication in whatever tier they wish to, and can say, well, we're going to cover this medication better than another. It's just the same as, I don't know if everybody is as familiar with all the different insulins out there, but there's things like Levemir, Lantus, Novolog, and all these different insulins. Some companies will cover Lantus better than Novolin or Novolog or Levemir or anything like that. It all just depends. It's the same thing as one company may pay really well for a respiratory medication. The next company may not pay for it at all. However, that's the work that we do when we do these comparisons, is finding those plans that cover all your medications and finding the one that also, while covering all of them, covers them as a combination the most effectively. Okay, does anybody have any more questions before I stop the recording? I'll give everybody an opportunity to ask any questions afterwards too. I'm not seeing anything. I'm going to give it about 10 or so seconds here.